Kia ora te marino kia papa pauna me te moana he ura I mā tātou I tēnei rā. Aroa atu, aroa mai, tātou I tātou. Haumri e hui e tāhi ui. Kei aku nui, kei aku rahi, kei aku rangatira nō hurunu o te ao, nau mai haere mai. Nau mai haere mai ki tēnei hui o tātou o te rōpu mātai, hauro pāpuru o Aotearoa. Te haukainga Ngāti tō rangatira, taranaki whānui o koutou maunga, o koutou awa, o koutou moana, tēnā rā koutou, e mihi ki a rātou kua whiturangi e tia, moe mai rā koutou, moe mai rā. Rātou ki a rātou, tātou ki a tātou, tēnā koutou katoa. Visitors, guests, people dialing in from both New Zealand and overseas, welcome to the third day of our online conference. The Public Health Observatory of New Zealand is thrilled to have you with us today, and we are most looking forward to today's presentations. I'd like to hand you over to Patrick now, who will pānui our housekeeping.
Well, good morning, everyone. As Peter says, just a few, oops, that's the wrong button, a few points of housekeeping. If you've got a question, you'll see in your menu bar that you've got a few options of actually getting in touch with us, the hosts or the panelists. So if you have a written question to submit, please use the Q&A option. Though if that doesn't work for you for whatever reason, there is still the option of using the chat as a backup. If you'd like to ask a question to a presenter out loud, then please use the raise hand button, and that will get our attention to let us know that you have a question. If you've got any general comments to make or need to get in touch with the hosts for things like tech support, leave the chat for that. So attendees, you'll notice that your microphones and cameras have been disabled by default. We will enable your microphone if you've got a question to ask directly. And for presenters, in the way of timekeeping, we're going to be ringing a bell when you are 13 minutes into your presentation, and the bell sounds like this. And so what this means is you should look to be wrapping up in the next couple of minutes in order to leave enough time for the Q&A at the end. We are recording this, of course, but no one has been in touch with me to say that they object to that, so that shouldn't be a problem. If you've got a video to share as part of your presentation or anything with audio, when you start sharing, make sure that you tick the share sound box when you're setting up, or you'll need to turn that on once you've started sharing your screen. I think that's everything to cover. Has anyone got any questions really quick before we get into it? That's good. All right. Over to our first presenter then.
Hi everyone, I'm Barry Borman. I'm the chair for this session, and welcome, as Peter has already greeted you, welcome to the third day of the PHONZ conference, which I must say proudly that it's been an outstanding success, and today I think is going to be even more successful for the quality of the presentations we've got. Our first speaker is in fact going to give two presentations. And Sala Senkayi is from the US EPA, and I have no idea what time it is over there in Atlanta, Sala, but welcome, and we look forward to your presentations.
Thank you so much, Barry. I'm going to attempt to share my screen. Let's see, we'll do that. We'll do this. Please let me know once you see my presentation. Hopefully everyone can, okay?
Yeah.
And thank you. And so yes, my name is Sala Senkayi, East African Ugandan name, so I'm an indigenous Ugandan. I want to say I'm extremely pleased to be here today. So just a huge thank you to the organizers and everyone watching from your respective locations. I probably want to turn off my camera for bandwidth if I can find that here. There we go. All right. And I will go extremely quickly through this presentation, but I do want to touch on some disclaimers. First of all, these a lot of things you're going to hear today are my views. I do work for the federal government. I work for EPA in Region 6, which is actually located in Dallas, Texas. And so it is 4 o'clock in the afternoon over here. But as I go through my presentation, please keep in mind that I will be talking about a lot of visualization tools, basically my journey here on my efforts to develop a lot of these tools and working with others in doing so. But just because you notice a visual relationship doesn't mean that the data and the information are related in any way. So I had to add this disclaimer to one of the tools that I have, is I thought it would be a good way to sort of open up this presentation. So I'm going to talk about several things today. I'm hovering over the first app that I'll talk about in my first part of my presentation. And this app was developed under what's called the Presidential Early Career Awards for Scientists and Engineers, and I won that in 2017. Provided to me by former President Barack Obama, and I've used those funds to develop this tool. The other thing that I'll talk about also in this first part is a tool that I'm working on to note bacterial areas of concerns or zones of concerns during flooding at the Gulf of Mexico or anywhere. Pretty much what we wanted to start with the Gulf of Mexico because of hurricanes. So I've been working with our group. It's called Office of Research and Development here, or ORD. And then the second part, we'll talk about some work that I've been doing in Uganda. So let's see, I'm pressing, there we go. So disclaimers are important for us here at the federal government. This one basically just states that, you know, just because you're noticing hotspots within the data sets and these tools, again, we need to ground truth some of the things that we're putting out there. So a lot of the things that I will be showing you has not been peer reviewed, but we're working on that on my end. Also, the important part here, just remember that collaborating with other agencies, other groups like a Massey University helps us better understand the information that we're visualizing. And it uses a very multi-dimensional approach of looking at information. So we've been using Click here at EPA, but I'll talk about some of the other tools. Just a quick background, back in the day when I was working on my dissertation, I looked for tools that can help you visualize information. So these are screenshots from some of the work that's been going on in New Zealand. We conversed with Barry back in the day and several others because we really liked this tool where we're looking at 2 maps and information surrounding it and a scatter plot that helps you note the highs in the top right. So some of the tools that you will see me demo actually have that look and feel. The importance of these tools, first of all, this was pulled off of the World Health Organization or the WHO's webpage, and it documents the under 5 mortality rate. It's important because now we can see those areas that don't have a problem with that and those areas that do, and I'm hovering over that right now. I've clicked on 3 countries here. So Congo is at 98, I'm pointing to that, which puts it right about here for 2015, and right about here, that tells us that Angola is higher, right? And then also that Ethiopia is the blue line. The good news with this data set is the downward trend, right? It's a sad data set, but there is good news. And so over time, we're seeing that downward trend. That's the benefit of using tools like this, so that in a few seconds, you're learning more about the data set. Also, I was able to work with our ORD, or Office of Research and Development, to publish some of my dissertation work after, again, I did that in about 2012. This is 2015. But these individuals were able to take total leukemia incidences for children 9 and under, within the state of Texas that was aggregated county level. This is not all of it, but I'm showing you the highs here. So what we're doing is we're looking from bottom left to top right, and we're noticing that trend, and we're noticing it alongside road emissions and airport emissions of benzene. So again, total leukemia cases for those 9 and under within those counties. And you see that general shape for both of these. And this is over a 10-year period for the leukemia incidences. We were, before submitting this information to Mark and his group, we were able to do a statistical analysis and found that there was indeed a relationship with airport benzene emissions and the cancer cases. So that brings me to now. Using the President's Award that was given to me, I was able to work with our ORD group. Again, Dr. Brian Chastain, he's the brain behind all of these tools that I will be demoing to you today. We're using CLIC. The one that I'm going to talk about first is the Regional Environmental Health Data Viz app or tool. And it shows US information by counties, and that one is actually online, so anyone can get to it. And I'll provide the link here before today is over. Benefits of using these tools, they help us identify gaps, right, over the years, especially consistency. We come out with a consistent message agency-wide, helps us prioritize areas of interest like counties within regions, state, or agency-wide. Also with bolstering tribal and EJ environmental justice, those are groups that typically need more assistance because low income and things like that historically over the years. So our EJ community resilience, and it assists with noting those communities that are marginalized, underserved, and overburdened by pollution, irrespective of their location. So whether they're in a rural area or densely populated city. I'll talk a little bit more about the first app and notes, all 3 apps that we've developed. You can download that information after you've looked at it. We've also worked with Cherokee Nation, which is a tribal indigenous group here in the States in Oklahoma. Thanks to them for providing some of their data and information. So our tool opens up like this. It has a quick disclaimer. I will take you around a tour of the US, but we added this because CDC wanted folks to know where to go to contact them, how to cite their work. This is that disclaimer that I talked about earlier.
To be the kind of
when I opened
specialist working with me on a new leprosy case.
The meeting, and we give a tip. Start with variable X and then go to variable Y. Once the tool opens up, it looks like this. Click here to go to our EPA homepages or here to download that data. The data source consists of EPA information, CDC information, our EJ screen information, or you can contact me. You can click and select states if you would like, but we won't do that now, just in a little bit. We have airport information, population information, farmland, rural areas, educational layers, a lead design, an air quality lead design, Cherokee Nation, Radon Nation information, and also that EJ screen, environmental justice information, wildfires, which is hot right now. We also have blood level, old homes, and then air quality, health, and environmental information in the tool. The tool goes from 2020 at the top there, all the way down to 1980. And we could go further if we had more information. You could also look through the years or sort through the data table. Everything is linked to the original source. So some of the information is coming from CDC or EPA, FAA, even the titles are linked. This is variable Y. So at the top is the highest for variable Y. I'm hovering over that right now. It's Los Angeles, California. And if I sort variable Y, you'll note it there, right? If I sort variable X, you'll note Lexington, Virginia is higher there, and it's the bottom axis. And I'm hovering over that right now. So the maps, everything is linked using CLIC. And as I hover over things, as you can see, things pop open. You'll see red areas circled. That's the beauty of the tool. Everything's connected. I'm hovering over the trend line, and you'll see that that information was collected in 2000. The average is 8,218. And I can do the same for the airport density, hover over that trend. It was taken in 2020 and the average is 0.01. So we're looking at areas that are highly densely populated with airports, in addition to variable Y, our old homes within the United States. And this is beautiful because as I zoom in to a region, now we're in the northwest, so Idaho, so this is region 10. You'll notice that as I click on the different states, the colors pop up, right? I'm clicking on Washington now. And you'll also notice that the scatter plot gets updated. I added Alaska, but I didn't want to pan back and forth, so I'm just sticking with these 3 states. So as I hover over the maps, they highlight the information in addition to the scatter plots. So you're noticing the highs and the lows and everything in between. That's the beauty of having a tool like this. Let's quickly move on to another region. We're going to go to region 9. And all I have to do here is type in California, select it, it turns green, meaning I've selected it, and there's a check, meaning there's information there. I can unselect the Idaho, Oregon, and Washington, the other 3 states. And you'll notice now the extent of the map just draws into California really relatively quickly. So I'm clicking on Arizona. I'm going to type in Nevada, click on that. And then I will add Hawaii just so you can see how far off it is. When I do that, you'll notice that the map gets smaller and you can't really see the details. So I will deselect it again by just clicking on it once, and then it goes back to normal. You'll see this beautiful relationship in the scatter plot where we're going from bottom left to top right with the data set. Even the maps kind of looks similar. What that tells us is, yes, indeed, airport density, there is a relationship with that and the old homes that you're seeing in the United States. And that's important because it was this region that asked me, at EPA, that asked me to actually include the airport density and airport count within the tool. So next, for variable X, I'm just going to quickly look at old homes. And then for variable Y, we'll throw in some health here really quickly. I'm going to look at the number of children who tested positive with blood lead levels between 5 to 10 micrograms per liter. And this would be an opposite relationship. What's also interesting is California, Nevada, they do not have data, at least for this year. So again, this helps us with our data gap. But you do notice a trend line, right? And as I deselect Arizona and California, because I'm going to type in New York and select New York and New Jersey, so we can journey off to the East Coast, which is our region 2 group. And I do want to deselect Nevada, so I will go back in there, let's click on it really quickly. And now we have zoomed in to our region 2. And notice New York has some missing information. I've added Puerto Rico just so we can see what it looks like. But as I filter through the data table, you'll notice that you don't see Puerto Rico listed anywhere. So I'm going to just really quickly hover over the map, see the highs and lows between old homes and the number of children who've tested between 5 to 10 for lead. And now we're going to journey to Puerto Rico to see if we can't find any information there really quickly. And as I do that and zoom in, you'll notice that the whole area is white, meaning we don't have any information. So the darker blue means the higher here, and the lighter colors mean lower. If it's completely white, we don't have any information. So I know our environmental justice, or our EJ screen, does. So I will click on percent minority for this particular, and there we go, for this particular area. And as I hover, you'll see the 0.98s, ones, it's kind of small, but I will show you exactly what that looks like. But there again, 0.97, 1 within the scatter plot. I'm going to sort the highest percent minority for these 3 areas. And as I do that, I want you to watch and see as the data table updates, right? So we know we have that for percent minority, but we don't have any information for old homes. And that's a problem with some of Puerto Rico. There just really isn't a lot of data. So I will deselect it and we will go back to New York and New Jersey and look at this particular data set and just notice that beautiful relationship within the scatter plot. So, and as I hover over the highs for variable X, you see that's the Bronx. So they have a lot of older homes there, and King County, high percent of minorities there. Next, we will travel really quickly to my region, and that consists of 5 states. So we'll start with New Mexico, and I will deselect New York and New Jersey. And as you see, New Mexico is highlighted down there at the bottom. Even when you're looking at the scatter plot, you'll notice that that changes. So the point here is the tool is so powerful that it will give you your response almost instantaneously as you click on the state. So New Mexico, Arkansas, Louisiana, Oklahoma, and Texas. And I reside in Dallas, Texas, which is the top right portion of the state of Texas there. Oklahoma, incidentally, a tribe in Oklahoma, northeast, provided us with some of their information and data. And so I will show that to you just really quickly. But moving on, I wanted to show you not only is this tool powerful in English, but you can also use Spanish. And I've just clicked on it and you can see this data table up here to the right, update to Spanish, right? And then I'm clicking so you can see Maori is here as well. Before I move forward with this, I just wanted to comment the low birth weights here and the PM2.5 that you're seeing. We notice this relationship, irrespective of if you're looking at all 3,000 plus counties within the United States, this almost exponential relationship. Or if you're looking at the different regions like we just did, or even some of the states show the same exact relationship. The good news here is there's a downward trend. Messaging probably should be that if you live in these areas and you're looking to have a baby, maybe exercise indoors instead of outdoors so that you can reduce your risk of having a low birth weight baby. Next, I'm just going to show you that this tool, again, is so powerful that you can look at it in other languages, right? Uganda, the language that I speak, hopefully they'll be getting that into the system soon. This is what I'm hearing. The benefit of a tool like this is the appetite, right? A lot of people are wanting these type of apps to help them educate themselves on the environment. And well done to Massey University, because I know that you all have had these type of tools for many, many years. But we're noticing an increase of folks visiting our page within the last year. This is the second tool. This one is on the intranet, so only EPA folks can get to it. But this is Cherokee Nation. Again, it's one of our tribal groups, our tribal partners here in the region. And this is data in relation to their area. Again, it's from our environmental justice EJ screen, but they did provide some lat long so we could look at it if we wanted to. And one can export that data if they wanted to learn more about Cherokee Nation area. So this block group has what we call TRI, so toxic release items. It also has our national emissions inventory, or NEI, our national air toxic assessments, our EJ screen, and several others in there. So we've worked really, really hard on developing that one. This is a tool that was developed outside of Click. I worked with software engineers at our ORD, and they actually put it together. I don't know if you can see it. There we go. The way it works is you have this hazard, right? And then as you're looking at areas, this hazard danger level will update. So you add the intensity, how dark red is it? You add the distance, the dispersion, and then you add a title, and then and doing all this by right-clicking, and then a dot will appear. And as you hover over different areas, you're noticing there's a logarithm behind the scenes. So you're noticing hazard danger level. So this is something that we've been thinking of to note bacteria and those zones of concerns of bacteria within the Gulf of Mexico during storms. Again, you add a title, you add the intensity, how red is it, the dispersion, and then you give it a name. So I've been working with ORD to further develop this. The problem is we don't have bacterial information to pull into it. So maybe partnering with other groups might help. We're looking for funding to finish this tool out. So more to come for sure. But as the individual John Eastman, who developed the tool, zooms in and out, you'll see by clicking on relative or absolute, the distance changes for each one of these. So relative to other points or sources of bacteria, or absolute for that particular point. He also added a linear sort of a regression here, or exponential. So as the pollutant disperses, is it a linear or exponential dispersion, right? So he actually did a really good job of putting this together. If we wanted to add other areas, this is how you would do it. He's actually showing you how to do it right here. This is a taped video, so I apologize if it's kind of not smooth. But you would click or add that file here for another area, or add your points if you are working with a subject matter expert and they have points where they know this is a bacterial source, they could do it there. And that's what that would look like for at least Houston, right? So the thinking is to add different areas to the tool. And you can turn on and off those dots. And as you do that, again, you're hovering over and there's a logarithm that spits out a number for that hazard danger level of bacteria. So interesting tools. I know I'm at the end of my first presentation, and what I will do is go ahead and start off with my second presentation, which is looking at an Embassy Science Fellow, or an ESF program that I participated here in the United States. I know I have a guest visitor, and when I get further on to his video, I will hopefully he will be able to unmute himself and say hello to everyone. But I worked with the Ugandan government to develop PM 2.5 air quality apps for Kampala. So the way this works was I applied for an MC Science Fellow, I was awarded it, and that started in 2018 to September 2018 to March 2019. I participated virtually only because I'd been to Africa, I've been to Uganda so several times to visit my grandmother and other family members. And so I was able to do it virtually, and that worked out well. At the bottom left here, you will see the emblem for the US Embassy. In the bottom right, you'll see the one for the Uganda. And again, that disclaimer holds. So just some background about air quality issues, right? So I happened to be working in San Francisco during the wildfires, the massive wildfires we had here in the States. That was in California and close to San Francisco, but that was back in November 15, 2018. As you can see here, I know many of you know what air quality index is, or AQI, but they're stating in this article that when it gets to 275, there should be some closures in San Francisco area. I mean, it can be really, really hard to breathe when these events occur. So 4 days later, November 19, 2018, I decided to see what the air quality index was for San Francisco on that particular day. It was 169, unhealthy. And about a minute before this, I was able to look up Kampala's and noted it was 171, and they were not having any closures. We incidentally had a government shutdown for about a month during this time. So I came back in February and looked up Kampala again and noted that it was at a 189 on a Sunday compared to 17 for Nairobi, Kenya. And most folks have heard of Nairobi. It's a larger city. So that's one of the reasons why I added it for reference. Just to give you an idea of the climate in Uganda, so the temperature rarely goes above 29 degrees Celsius or 84 degrees Fahrenheit, which is what we use here in the States. On average, they're seeing 26 degrees, right? The rainy season actually starts in March, and that's really, really important when you look at some of the information, air quality information that's coming out of Uganda. Just for reference, this is where Uganda sits. This is Lake Nalubale, or Lake Victoria, as most folks have heard of. I would be remiss if I did not show you how beautiful the country is, just a beautiful country. Unfortunately, they're starting to see days like this, right? This is kind of dated, but these next series of slides were provided to me from Kampala, and they show you that with respect to air pollution in Uganda, the WHO guideline is 10, but they're at that time we're seeing 10 times higher, right? It's not just an air quality burden, it's also a health burden. They noted 31 plus individuals had died that year because of air quality. And just to give you some more reference, I Googled and found out that Canada has a similar population as Uganda. However, they're only seeing 5,000 deaths per year due to poor air quality. again, this is a global issue. 9 out of 10 people worldwide do not breathe clean air. Air pollution was responsible for 7 million premature deaths in 2016. And of those, 600,000 were children under 5. Again, environmental justice, EJ, because the kids are not creating this, but yet they're suffering the negative consequences. This is an annual average 2018 AQI. Notice Beijing had some missing data at the end of the year. However, one thing that struck me was in March, we're seeing Kampala with the lowest AQI for that year, and Kampala's in orange. And at the end of the year, they're actually worse off than the other 2 cities. So that's interesting to note. This, again, was provided by the Ugandans. Notice they have this baseline inventory that was taken in 2009. The way to read this is emission type here. We're concerned with PM 2.5. That's all I worked on. And they're noting that a majority of that, 86+% comes from domestic sources. With respect to the Embassy Science Fellow, or ESF is what I'll call it, what happens is the host country, in this case, that's Uganda, requests help or assistance from the US Embassy. And then the US Embassy looks at applicants from all federal partners and decide who can actually help the embassy, the host embassy, with their requests. And so I was really lucky. I applied, I got to work with them. The benefit here is I was able to develop an app for a country that I love so much because I'm originally from Uganda. Also, I got to work with extremely smart people from Massey University. USAID was supposed to participate, but 2020 is when she was going to go, and we had the shelter in place due to Corona. NEMA, which is the National Environment Management Authority, it's the equivalent to EPA in Uganda, also participated. Kampala, Capital City Authority, or KCCA, as you've heard me say, participated, and so did Makerere University, which incidentally is the university my dad went to. And he currently works at EPA Region 6 with me here in Dallas. Having said all of that, there were a lot of people who assisted with this task. They did a lot of the hard, heavy lifting. All I did was to develop, get the information from them and develop the tools I'm about to show you here. The good news is about a month or so after I finished, Kampala, the folks who worked on this were able to get a $1 million Google grant to develop an app. And so they came to the US and they have since developed an app. And you'll see that it looks very, very similar to what I was able to provide them, which is excellent, right? And you'll see that in the video that I'll play a little bit later on here. Just know that, again, I helped develop beta tools for them, and they took it further, obviously. I also helped with taping educational webinars, providing comments from all over on their air quality proposal and their Ugandan school educational proposal. And then, of course, giving presentations like this one. So this is the first tool, and I'll show you this screenshot, and then the next slide will be a video of an updated version. But we have a map, right? We have a data table. This will actually turn into a bar chart so you could see the information. And then we have this time series. You click here, and then it starts to go from 0 to 24 hours. And then you notice the data and the information kind of hug the left and span out at the end of the day in Uganda. So this is the tool in action. The information I pulled off of a publication online, and one of the gentlemen who participated in my ESF actually published that work. So I'm zooming in and out of the map, and you can see Lake Victoria, Lake Nalubale there. And as I zoom in, this gentleman had gone to Kampala and also to Jinja, which is a neighboring city. It's a smaller city. It's not as big. It's not industrialized as Kampala. And so you can definitely see that I'm even having problems noting or hovering over to get that air quality. It's a smaller contribution to particulate matter than Kampala. But as I click on commercial area, you see it's red, it's Kampala. This is color coded, which is nice too. Click on industry, you see Kampala has that. Then I click on unpaved roads, and Jinja, this small city, actually has more PM2.5 due to unpaved roads. Then when you pave it, it goes down drastically. This speaks to the benefit of actually paving roads, but use something environmentally friendly so you don't cause another environmental problem. And as you see, I click the time series, and over the day, almost to the 24 hours, we're starting to see the increase in air PM2.5 and air pollution there. This is another tool I created for them. They downloaded what's called Air Now information. So the US put in an Air Now sensor in Kampala, and they put it there for 2 years. So you can see it starts in January and goes through January 2017 to the end of 2018. 16,000 rows, right? Because every hour they were taking a measurement. So they took that from Air Now, downloaded it, gave it to me, and also provided me something called Nowcast. So it took similar data. They wanted to ensure that when they used one or the other, the information will be the same. So looking at the scatter plot, you do see Air Now at this axis and the Nowcast here, and you notice that it's almost aligned. So yes, they can use either or. And I believe that Air Now sensor has been moved to another country in Africa. So every 2 years it's being moved somewhere else. So I averaged for the Air Now on the bottom left and the Nowcast on the bottom right. Notice in March, we're actually seeing good readings. So that's good, because that's what we would have expected from previous information that was provided to me, right? And some of the educational material that I was reviewing. I also averaged it out by hour, and this is what it looks like for the Nowcast at least. Hazardous, they're noticing that late in the night, almost the 24th hour. With respect to good readings, they're getting that in the morning and also late at night. But in the evening, for some reason, they're not seeing any good readings for 2 solid years. So that got me thinking, what could be happening in the evening? Because we know people drive to work and then also drive home. So there must be other things that are going on in addition to the driving and the industry. Turns out there's a group called Center for Research in Energy and Energy Conservation, CREEC, and they do a lot of research on cook stoves. They noted that most of Uganda either burns firewood or charcoal. Only a small area actually uses electricity for cooking. They do testing, and this is one of those portable cook stoves that Uganda actually develops. They developed some, I'm not sure if this is the exact one. Having said that, you can see all the particulate matter that's coming off, all the pollution is coming off of one of these. So typically women cook and they have their children with them. That brings me to what health related issues are you noticing in Uganda? This was a CREEC refugee study that was done in 2018. And you notice all of these elements. So who are you seeing going into the hospitals with these health challenges? That's one of the questions I asked the Ugandans. And hopefully, I believe they probably are working on addressing this. So this next slide is a short 5-minute video that'll talk about some of the traffic issues that. Thank you. And so Michael Wanyama, if you're online and can unmute yourself and say hello, would you like to do that before I play your video up next?
Hi, everyone. Can you hear me?
I can hear you, Michael. Thank you. Go ahead.
Yeah. Thank you very much, Dr. Sala. I thank everyone who is on listening or watching here. It's a pleasure being part of this, and thank you for bringing out the word for the works we are doing. We are just part of the many movements within the country that are trying to improve air quality. And for us as a team, most of our expertise lies within the transport sector, and so we are working with the Ministry of Transport, Works and Transport, plus Makerere University under their Air Co project for the air quality monitoring. We are doing community-based workshops basically to improve automotive maintenance and also to try to gear citizens away from using fossil fuels, because Uganda mostly imports used vehicles. Many of these come with failed emission control systems, and when they come here, the maintenance, the way that they are maintained, only worsens because most of the roads are unpaved. You find that these old vehicles running on unpaved roads are being maintained poorly because of most of our mechanics. Actually, from our studies, over 85% of our local mechanics never received any kind of training in their lines of business. So it turns out that their practices highly increase the emissions that are coming out of vehicles. Now, you find that the children, the people that do not participate in the creation of emissions, they suffer the most, especially in the urban poor communities. So we are working with government and related agencies. We are still a startup, but at least we have been able to achieve a lot with very minimal resources, and we are pushing hard to forward this, to move it forward with it. We believe that maybe in a few years to come, we will have put up something that really helps to improve air quality in Uganda for better public health and also for our planet. Thank you very much.
Thank you, Michael. And I'll go ahead and start your video.
Air pollution is the largest environmental threat to human health, especially to infants with their little lungs still under development. And yet, it's one of those things that go unnoticed by many or not given a thought by the few that notice it. Transport is still the largest contributor of carbon monoxide and smog, also the second largest source of hydrocarbons and nitrogen oxides, the most common air pollutants. In Uganda, over 31,600 people die annually from air pollution-related illnesses like acute lower respiratory infections in children, asthma, lung cancer, heart disease, to mention but a few. There are very alarming levels of air pollution in urban centers, largely contributed by road transport and industrial operations, because we lack strict laws and regulations on emissions, coupled with poor maintenance of automobiles and industrial or domestic equipment running on fossil fuels. The general public's attitude towards environmental safety in Uganda is too low. Our research, through collaboration with a few well-organized local motor garages and automotive experts, revealed that most automobiles and related equipment which have been operating in Uganda for over 5 years, especially diesel trucks, buses, commuter taxis, and several industrial equipment, have non-function emission control systems, courtesy of the limited capacity of mechanics maintaining them. There is heavy presence of counterfeit automobile parts and accessories on the local market that hinder complete combustion, plus those that facilitate increased non-exhaust emissions. Motorists are unaware of the danger their driving habits bring to their own health and to the general public, especially those vulnerable ones who never take part in the creation of emissions. Heavy traffic congestion coupled with too much idling is usually caused by inexperienced and self-centered motorists. Many drivers keep engines running even for relatively longer stops, partly because they are not aware of heavy toxicity from an idling engine, while some fear for their engine's failure to start immediately. Mechanically ill automobiles dominate the roads in Uganda. Overloading is a common practice in cargo and public transport.
Okay, so I'm going to go ahead and stop the video, but you heard a little bit about it, and hopefully Michael can provide the video link and a link to his company that's working on a lot of these issues. And as he mentioned, it's not just his group, but there are other groups as well. This will just show you, this is just world's 20 most populated megacities according to Global Cities. And they're saying that 13 African cities will surpass New York, and that was New York. And this is, Kampala is actually one of those cities that will surpass New York. According to the WHO, Uganda's current and future climate hazards, just really quickly, when it comes to mean temperature, if we do business as usual, it's this orange area. And from 1990 to 2100, Uganda will see a 4.7 degrees Celsius increase. However, if we curb our global or decrease our global emissions, then that'll be only a 1.3. Same here with the heat waves. If we do business as usual, they'll see 225 days compared to just 10 in 1990. However, if we curb our global emissions, that's all of us, then they'll only see on average 65 days. But they are moving forward. I have seen other Embassy Science Fellows and other projects related to this. You've heard from Michael Wanyama in Uganda. And so there are a lot of folks who are addressing and working towards solutions. I've actually gone over every single item here. I'm providing my contact information. And Michael, please put your link in the chat so that folks can watch the rest of that video. I just wanted to give them a taste of that. And I will be putting in the chat the link to the app that I demoed here. And with that, I will turn back on my camera. Let me see if I can stop sharing. Okay. And if anyone has any general questions, I want to thank everybody for your time and your efforts and all that you do on your end. So Barry, I'll hand it back over to you.
Thank you, Sala, and thank you, Michael. And it's great to know that we've extended our reach both to the EPA and to Uganda. So that's wonderful. And also, I must compliment you on the fact that you've got your translation to our local language, Maori. So that was very good. And I see our colleagues from the Ministry of Health are giving you a thumbs up on that. So actually, we don't have time for questions, but if there are, anybody does have a question, put it in the chat room and we will forward that on to Sala. As I said, we're delighted that we were part of the collaboration with you, Sala, and we look forward to both continuing your involvement with PHONZ and your colleagues and working with you in the future. So thank you once again. Great presentation. Thank you.
Thank you.
Okay, so following on from that, we have our colleagues now from the Ministry of Health, Moya and Hineamaru, and they are both going to give us a presentation on what COVID-19 has taught us about data sharing with Maori. So over to both of you.
Kia ora tātou. While Moya's sharing screens, I will begin with mihi tuatahi. I te timatanga ko te kupu, ko te kupu, ko te atua no tawa kupu, e mihi ana ki te rangi, e mihi ana ki te whenua, e mihi ana ki ngā tangata katoa. Ko ai au, ko Hineamaru Davies-Lyndon, no ngā pohi nui tonu me ngā titua rangatira hau, e mihi nei kia koe, Peter, kia tātou katoa I tēnei rā whakahirahira. Kia ora everyone, my name is Hineamaru Davies-Lyndon and I hail from the sunny winterless Northland in Aotearoa, New Zealand, and also from Takapawahia here in Wellington. I work for Te Whatu Ora Health NZ, Senior Advisor in National Immunisation Program, and honoured to be here to share our work for data sharing Ngāraronga, Whānui, Mo Aotearoa, and I'll hand it over now to my colleague Moya for mihi and start our presentation. Kia ora.
Ngā mihi Hineamaru. Kia ora koutou, ngā mihi nui kia koutou kākoa. Ko tānui tuaka, ko tararua ngā paumaunga, ko Waibari te roto, ko Ohau te awa. Ko Ngāti Rau te kawa ki te tonga te iwi ki Kikopiri te marae, ko Moya Field ahau. Morning everyone, my name is Moya Field. I am part of the team that is involved with data sharing with our Māori partners in the National Immunisation Program. A little bit about me, I hail from a tiny little coastal rural town called Tugmawana in the mighty Manawatu, but I live here in Wellington. I'm a social worker by trade. I've worked in health and social care for many years, both here and in the UK. I've been a frontline social worker. I've worked in projects and policy, leadership and strategy. and always been adjacent to data. So I suppose, first, thank you very much for having us. We're really, really honoured to be here, and mihi to you, Peter Himona, for the invitation. So Hineamaru and I are part of a data sharing team within Masako Wada. The team was established in October 21, basically to support the sharing of COVID-19 data. And initially, we're set up. We've got a range of expertise in the team, and we work really, really closely with a working group that's very specific to data sharing, and it includes data technicians, the Market Health Directorate, legal experts, privacy, data governance, and a whole lot of smart technicians. I guess the purpose of us coming today is to share with you a little bit about our experience sharing data, and in particular into the Māori space, and our role within that process. So I'll start from the beginning. I'm very excited that the tech's working. It's always a good way to start. So just in terms of our kaupapa, Masako Wada is patriarchate for a whole bunch of health data sets. And within that role, we have a whole, where I guess we're always managing that tension between individual rights to privacy and our role in protecting population health. And during the pandemic, it's kind of presented a very, very highly unique set of circumstances in terms of data sharing. Because COVID-19 was considered a threat to the health of all New Zealanders, we had that gave us a mandate to share data in a way that we hadn't in the past. So this work has carved some pretty new ground, not only in terms of data sharing, but actually the relationships that we have begun to develop around data. So ultimately, in terms of the pandemic, vaccination was seen as the greatest mechanism for protection. So our ultimate goal has been to protect individuals through the vaccination program, and communities through the vaccination program. But in order to do that, we actually need to know who they are and where they are, and we need to be able to share that information with the people that are reaching into those communities. And so part of the role, I'll just give this to, I'm not going to talk too deeply to this, but this is a bit of a timeline of the work that has been done since March of 2020. Originally, our team was set up mainly around the vaccination order, and we managed all the data sharing requests for mandated workers, and we created data sharing agreements with employers and connected those two pieces together. So that was actually the beginning function of our team. In mid-2021, there was some initial conversations held with the Whānau Order Commissioning Agency, and they were very, very keen to get data around vaccination. Those conversations kind of resulted in a bit of an unmet need from the Whānau Order Commissioning Agency. They were asking for data, and they were at a stalemate, so they actually initiated legal proceedings. And what I mean, it was complex, but ultimately they were successful in carving a path for data sharing with Māori. So the court case resulted in the ruling in favour of the Whānau Order Commissioning Agency, and off the back of that, that initiated the then Ministry of Health to engage with Māori. A number of Māori organisations with iwi to actually try and get an understanding of whether there was appetite for data in Māori communities. And the outcome of that engagement was that there was an overwhelming appetite for data. And so that kind of set a path for us needing to work through what mandate we would have to share data, how we might share data, with Māori. It also created employment for Hineamaru and I. And so that's kind of where the basis of this work in our role has begun. You know, the court case, there was a lot of conversation around it, but ultimately it cut a path to data sharing with Māori that has been both established and grown over the last 6 to 12 months. And so part of our role in our team is, I guess, for us to be ever mindful of where our te tiriti obligations sit in relation to data. I mean, in the Himona report, the Waitangi Tribunal Himona report, they make things very, very clear. And we've kind of used this as a mantra for our work. And I quote, if Māori health and whānau order providers are to be effective, the Crown must adequately resource them to carry out their job. This includes, where practicable, providing them with data that would assist them with their efforts. It also includes funding, resources, and other types of support. And so ultimately, that's kind of the place in which we operate from. We know it's the right thing to do. Data sharing, we're always and constantly managing that tension between population health and individual health information and people's individual rights to privacy. I need to meet to the people that began this work with us, because actually they cut a big path for us in establishing mechanisms for data sharing, a legal mandate for data sharing, and created those initial relationships that we, Hineamaru and I, maintain and as part of our work. You know, our BAU positioning around data sharing, in particular with Māori, is often that our legal and privacy frameworks overshadows our te tiriti obligations, and I suppose part of our role in the team is to continually keep our obligations and commitments to Māori at the forefront of what we do, and that they are pitched up alongside our legal and privacy requirements. They're always considered as a whole rather than in isolation from the legal and privacy and risk around those areas. So, you know, we consider data sharing as an active partnership. If we want Māori organisations and iwi to be part of the effort to vaccinate our population, then they need information. I guess we wouldn't, as a ministry, or at Te Whatu Order, we wouldn't try to understand a situation without data, and the same applies in communities. We have seen firsthand in the partnerships that we manage the value of providing data, how it enables self-determination in mana motahaki, because it promotes decision-making and actions within communities, and those actions create options for people in communities, and we can talk a little bit more to that as we go along in terms of some of the successes of the data sharing. Ultimately, our goal is to increase the vaccination rates for Māori, but the evidence that's come back as part of the work that we do is also this works for non-Māori too. So the providers that we share into are not just servicing Māori, they're servicing whole populations. I suppose the question about why we share data, it's the same, right? We get it. It provides insight and understanding around population needs. It helps people to make decisions and prioritise and bring vaccinations into communities. And what we have seen is that it also lifts vaccination rates. And so I'm going to hand over to Hineamaru, and she's going to talk a little bit to how we share data before we talk about some of the successes and some of the challenges that we face in this lane.
Kia ora koutou. So on the slide it shows the data release pathway from the beginning, usually iwi groups can contact Te Whatu Ora, but now due to ongoing processes, there's various channels. There's channels through our internal and external communications and teams. We mihi to the equity and mobilisation teams, because they're on the ground with our people, so they connect with us and link us in with the various groups. They then engage with us, which is a big part, because I must say, in the past, Māori have had difficulties working with Crown agencies, and so this is a great step with us building relationships with them. We then engage with the data sharing agreement, which is supports each other in that we maintain that we're sharing what they request and that we adhere to also supporting them right through. We're just not sharing data and then saying, kapai, that's it. Moya and I ensure that we support them through the different processes. We then share within a secure pipeline from our data technician team. The providers get data expert from our Te Whatu Ora, which work with them also. Once we extract the data to them, then that's the data sharing process, and we follow up weekly to ensure that everything is going great. But in a nutshell, we listen to them, how we make sure our partners are safe. We ensure we're here to commit and build this on a high trust relationship, making sure that we collaborate and have great transparency across our work. We share aggregated and mesh block data, which will show in our next slide what this represents across Aotearoa. We also make sure the security or the repository of this data is safe, and the relationships that we have, it's usually with the CEO or the chair, and then they ensure that this is protected. We weigh up, we continue with our te tiriti obligations and ensure privacy considerations are in place, that this maintains our operational guidelines that we support and effective use of the data is being adhered to. Kia ora mai, next slide. Here's an awesome slide, Māori data sharing partners. So in the beginning we started, last year we started with 4. 2 large partners, Data Iwi Leaders Group and also Whānau Ora Commissioning Group, who share across Tika Maui and Data Iwi Leaders in the South Island also, and they are an umbrella to various iwi, so that they have awesome platforms that we also support with the data. Then we have, for example, different runanga and iwi and trust boards that have another iwi registration that is a way to capture our people also. And then we have our Māori hauora, for example, hauora Hokianga, Ngāti Pro hauora, which are large rural areas that our whānau have high need for this data to be shared. So we have 27 partners at the moment building this capacity and capability across to ensure that our iwi data sharing agreements are supporting as a whole. And I think our last one I will share back with Moya. To end, I'll just like to say data is taonga, and we're here to honour our kaupapa being te tiriti partners and also work in collaboration, which is big. And I mihi also to Te Aka Whaiora, Māori Health Authority, and to all the people in this space working hard to support. Nō reira, tēnā koutou. Kia ora, Moya.
Yeah, I mean, I know that we're very short of time, so I'll just wrap this up quite quickly. It's been a challenging environment to work in because it's new ground. It's very hard to keep pace with our partners. They're on the ground, they're doing the mahi, and often some of the decisions they need quick, and sometimes the system doesn't really enable that. You know, because this is new, there's a lot of heightened risk aversion, but when we sit inside these partnerships, we're very confident of them. We only can see the value of them. We know that more resourcing is needed to uplift the capability and capacity of our partners because they're under the pump most of the time and working so hard in their communities to do this work with us. Ultimately, we know it's been successful because they've told us it has. They've told us that they use it to target concentrated vaccination plans, really clear. They take the vaccinations out into communities. They go into schools, they park buses up in streets where vaccination rates are low. They're very proactive. For the Whānau Water Commissioning Agency, so far they have done 851,000 plus COVID vaccinations and are still doing week on week hundreds of vaccinations in that space. You know, what we've learned is we know data is not a silver bullet. We know that, but much of what we do is actually about the partnerships that we create around the data. We know that sharing this information into Māori communities has helped them to reach their people, and we also know that traditional methods don't always get data to where it needs to go, and so we're working with that. And we know that data is at its most powerful when it's able to sit alongside local knowledge. And one of the big things is that communities need support and investment to build their capability for the future. And this is the stuff that we will plan to do. We want to share more. We've just been given permission to share national immunisation program data for the first time with our partners. And we want to listen to what they actually do with the data and use it to influence us in the future. Apologies, we've run a bit over, but if there are questions, we are more than happy to answer them in the chat. And again, thank you very, very much for having us. It went very fast. But yeah, it's a real honour to be here. Kia ora.
Well, thank you to you both. I think that was an excellent presentation and absolutely timely. I think all of us that have lived through the COVID will have seen the ups and downs, and I think the progress in what you've outlined is absolutely critical, and congratulations to you. We don't have time for questions, but again, if people want to enter that into the Q&A or the chat, I'm sure both of you will be very pleased to answer those. But once again, thank you. A wonderful presentation. Thank you. It's now my pleasure to welcome Justine O'Reilly, who's logged in, and welcome. PHONZ is delighted to hear your presentation, so the floor is yours.
Thank you. Tēnā koutou katoa, ko Justine O'Reilly tōku anō no Ōtepoti Ahau. I'm currently the Chief Advisor Equity with the Māori Health Directorate, and I'm here to talk to you about the work that we've been doing for the last about year and a half, which is developing what we're calling the Commissioning for Priority approach. And it really is about, at its heart, bringing the whānau order vision into the health system. So whakamoa was one of the key deliverables under whakamoa was to improve the way we commission. So commissioning is more than contracting, and it is the end-to-end process. But the key to commissioning is starting with purpose, and then that drives the entire system. So shall we start that again? So this is the Commissioning for Priority, and if you just click to the next slide, thanks, Peter. So as I said, it's a deliverable under whakamoa. It tracks all the way back though to the Royal Commission into Structural Racism and Discrimination within the public service back from the 1980s. We also drew on a lot of understanding from the Y2575 inquiry into primary community care. Also, Tiparonga research, there's a whole lot of research done led by Te Puna Kokiri, also with the Ministry of Pacific People and the Ministry of Health, and that was looking at how to improve primary and community care and to have more of a whānau order vision. So we've drawn all of these different strands of research together. We've also looked into things like human learning systems, a whole lot of work on commissioning, and also sort of the economic case and behavioural economics. So there's a whole lot of research that's been pulled together, and we also undertook a whole lot of case studies where we looked at the different stages of the commissioning process, from purpose understanding through to design, delivery and assessment, and also different levels from national through to regional and local. And we were anticipating the new environment with localities, and also the increased delivery of on the ground investment. And so we've also tried to make sure that when we're looking at it, often in health you default to services, and actually there's a whole missing suite of investment, which is community whānau capability and capacity building. So if we just go on to the next slide, thanks Peter. So with conventional commissioning, often it starts with what the system assumes that you want, or what people want, and it sort of delivers to people things that they think are good. And often within health, it's done in a disease and deficit approach, where you're healing one little bit of the body at a time, and it's not really a holistic system. And when it gets slightly improved, you have a little bit of co-design, but that's usually wrapped around something that's already been decided. So you've decided a service is the best response rather than other forms of investment. So with the commissioning for Paiora, we flip it on its head and we start with deeply understanding whānau, their communities and their context and their strengths, and then everything else acts as an enablement. So you have people who are on the ground understanding, you know, what are the resources, the strengths, the capability, and then funders or commissioners are looking at how they can support what already exists and then respond in a way that works for people. So a good example is the Māori Women Smoking Initiative. So what was happening was young Māori women are smoking at a much higher rate. The services that were offered were basically, you come to us in the centre and you have to say that you want to give up smoking by the time you walk in. And then working through this process with young Māori women, it was a case of that doesn't work for them. So working like in an individualised way, it went to more of a group setting, focusing on them as, you know, whole people. And then at the right time, smoking would come up as something that they wanted to have support with. And also a 4-week program was insufficient. So it's really thinking around what works for people and their circumstances. So the reason why commissioning really matters is in health, there's about $20 billion a year that supports the whole health ecosystem, but about 10 billion of that is through commission services. So it's like quite a large amount of investment. We also know that about 70% of what influences health outcomes sits outside folks' health direct ability to influence, and so really treating people in a holistic way matters, and changing the environment in which they live also matters. So just go on to the next slide, please, Peter. So some of the features behind the commissioning for Paiora are that it's grounded in nativity. So active protection is part of it. So some of the investment again is not services, it's about changing environments for people. It seems to have frozen. Oh dear. It's strongly evidence-based. It starts with a broader understanding of not just services, but also you know, the whole investment you can make, and it has key enablers supporting it. So you can't actually do this unless you've got the right workforce, the right data and insights. And it's also supported by the anti-racism and pro-equity work program, which is Omaitara. And I think Kylie might be doing some presentations on that to this group later. And also it requires collaboration from whānau, cross sector and the different levels to join up. But a key thing to this is in the new health and disability environment, there's a large investment in localities. But one of the challenges that we have, and the Productivity Commission report Together Alone also raised this, is often you come across things that you can't change at a local level. So the way Treasury does its appropriations can act as a blocker to cross-sector collaboration. So it's going right back into the system conditions and making sure that those are surfaced and challenged. And so that can sometimes be the thing that stops you being able to move from like a prototype environment to getting sustainable long-term funding. And so this is the both connecting local back to system conditions. And often those things look like they're neutral, but they actually have quite a discriminatory impact on the system. So those are the really big things that we're aiming for, and also trying to connect up commissioning so it's part of the bigger ecosystem. So commissioning is one type of lever that government can use, but you can also use regulation and you can use policy settings. So an example, when I used to work at MSD years ago, when it came to people getting into high levels of what they call problem debt, it was because people couldn't access good quality lines of credit, and so they'd go to fringe lenders and then they'd be charged like 1,000%. So they'd end up with this huge amount of debt. And the response was to give people a pamphlet and send them to a budgeting service. So that is a really low-level service-based response, when now what has happened is the stronger regulations around basically loan sharks. And so it's making sure that you don't just look at commissioning as one response, you also make sure it's working with your other levers. Peter, could you go to the next slide, please? So you can't read this, but it's basically, it's a maturity model. So commissioning for PHONZ isn't really so much a static thing. It's basically a 10-year change management program. And we look at all the different agents within the system need to go on a journey of maturity. So whānau have been treated as passive recipients of care. So we've got to enable them to become active participants in their care journey. Service deliverers need to be able to work in a way that supports continuous improvement rather than sort of compliance-based activity. And with commissioners, there needs to be a place of humility where you seek to listen, understand and support what matters to people. And then the central agencies need to work out what are the things that drive the barriers and constraints, but and those neutral things like Treasury appropriations. And Treasury are on a journey towards looking at how you can invest for wellbeing. So we have a public management system that drives you into sort of siloed ways of thinking because of our accountability structures. So when you're going for wellbeing, you can no longer look at just straight attribution, because in a way, outputs are nice and easy to track. You know, you've got money for this, you deliver that. But when you're looking at wellbeing, it's much more of a how do you tell the contribution story. So there's a real challenge for people in that data insights and measurement space to tell the investment. So that's where things like the IDI and the sort of bigger levers for assessing impact are really, really powerful. Next slide, please, Peter. So when does commissioning happen? Most people think of it as a sort of an annual cycle, but there's also commissioning occurs, as we've seen through the COVID work. Sorry, I don't know what that was at that time. Okay, sorry. Might just get you to zip through to the one with Mr. T, Peter.
There's two more minutes.
Okay, could you go through to the slide with Mr. T on it, the graphic? So we've got a whole series of case studies. All the way through we go, the shifts you need to make, that's the legislative environment and how that's changed. This one here I just wanted to talk about. So we did something that's missing in the literature is how do you actually quantify the human and system costs? So we worked with Just Economics and we looked at, this is the Priority commissioning framework here, whānau and people at the top, delivery, and then the system down the bottom. So these are based on 3 real people. This is Mr. T, who started off as a business owner at the beginning of this journey. What happened is he basically received discriminatory and poor quality treatment for his, at the start, undiagnosed IBS. And the bottom pathway was what was happening in the worst case scenario for him. The middle pathway is when Te Kakano started working with him, rebuilt his trust in the health system and got him better quality care. Then the top pathway is what would have happened if he'd received the best care from you. And then you can see the cost to the system with state and then the cost to him as a person. These are very, very conservative. They've been clinically peer reviewed, they're based on the evidence, and they're all fully consented as well. So you can see that if he'd had better quality care, it would have been, you know, better for him economically. He also started off as a business owner and then ended up as a beneficiary. So there's a really robust case study behind this. It's pretty heartbreaking when you see it quantified. So when the transition unit asked us to provide examples of what it is like when you work in a way that's more whānau centered and more strength-based and more holistic, the answer was we had nothing that allowed us to quantify. So this is the beginning of a journey. And the reason why this matters is when you want to move from prototype funding to sustainable funding, you've got to go through the business process with Treasury. And so we are trying to build up our capability to have economic values around things that, you know, in a way you can't value human life, but you sort of have to in our business processes. So this is a way of helping tell those stories, but we also always make sure that we have human costs as well as the system costs to really recognise and honour that. I'm sorry, that was quite rushed near the end, but these will all be public. There's about 13 case studies and the guide coming out, and that's quite a rich summary of what we've done. The World Health Organization is also profiling it as one of the examples of putting whānau at the heart of what we do. Thanks.
Thanks, Justine. And I must say I've been well enlightened with your presentation and the previous two, and it's good to have these out in a public forum where it's sort of unraveling some of the mysteries of what goes on in, perhaps in Wellington for others. So thank you for that. It is unfortunate we had to rush through those, but I think the slides and everything will be there. And in fact, we can put together that and we can put it on the website as well. So if anybody has any questions, there's the chat or the Q&A is available there for people. I'm sure Justine is more than happy. But the fact that we had to push through a bit faster than we might have liked, we'll get those all the slides and everything put on the website if that's okay with you, Justine.
Yeah, that's great.
Thank you.
I'm sorry, Barry, a bit of housekeeping for any presenters who may have joined us late. So the sound of the bell that you may be hearing is to let you know that you have 8 minutes left in your presentation slot. So that means if you hear the bell, once again, that you should think about wrapping up your presentation so that you will have time left for Q&A.
Okay, thank you, Patrick. Our next speaker is Peter, and Peter has been playing a starring role throughout PHONZ in the back room and helping us in the steering group. And Peter's going to talk about how one age standardised rate can hide inequity. Peter, welcome.
I'm Peter Himona. I'm a senior analyst on the Māori Health Insights team. I've been in this role for 14 years, and as Barry said, I'm going to talk to you about how one age standardised rate can hide inequity. First of all, why do we age standardise? We age standardise because it's a useful tool to compare groups with different age groups. It removes the differing age structures. For example, this is a population pyramid, and it shows the age structure of Māori and non-Māori in 2018 according to Stats New Zealand population projections. Now, when I look at this, the first thing I see is, can you see my little thing going around there? No?
Yeah, we can see it, Peter.
Okay, on the bottom left-hand side, you can see that the blue lines are quite bigger than the orange lines on the right-hand side. So this means that, so like in the 0 to 4 age group, 10% of Māori in this age group, but only 5% of non-Māori people. And in fact, 31% of Māori age less than 15 and 17% of non-Māori age less than 15. In the older groups, the opposite applies. You can see the blue lines are quite narrow, so like 65 plus, and the orange lines are a lot longer. So 6% of Māori in that age group and 17% of non-Māori in that age group. So what this has got to do with all of this is that some of the reasons why the blue lines are long in the bottom is because Māori have a higher birth rate than non-Māori. So in 2021, the Māori birth rate was 1.7 times that of non-Māori. And why are they shorter in the older age groups? There's a few reasons, but some of them are, on average, Māori life expectancy is 7 years less than non-Māori, and also many long-term conditions are associated with aging, so they affect Māori more and at a lower age, younger age. So that helps explain why they narrower at the top. Why do we age standardise? Well, one age standardised rate is easy to understand. These are publicly funded hospital discharges in 2009-10 to 2018-19. And you can see that it's pretty consistent throughout this period. Over this 10 years, the rate per 1,000 people is 50 higher for females than males. It's quite consistent, and the gap between the two is quite even. So if we had funding to tackle hospital discharges, would we concentrate on males? Well, maybe we would, maybe we wouldn't. This graph shows age-specific rates. Age-specific rates are not age-standardised. It's the number of people in an age group with the condition, or the number of events in that age group divided by the age population. And you can see on this, the blue lines for male are actually higher in the age groups less than 15 and higher than 55. And if you think back to that previous graph, it was quite even for males and females, but this is quite different. And so in most of the age groups, the rates for males are higher, but the rates for females are higher in the age bearing ages. So it shows a different picture to the graph before, and these are rates, they're not numbers. So if you were wanting to target the age groups with the most people in it, it's often not the group with the highest rates. For instance, in the population period, the smallest bars were on the top, but here the biggest bars are in that same age group, in the older age group. What I'm showing you, the age groups and ethnicity, they're just examples. They're not the only way you can do it. It's just the flavour that we have here at the ministry. So when you look at the difference in hospital discharges for males and females, you can see Māori male rates are higher than non-Māori rates, and the same for Māori females and their non-male Māori counterparts. The female one is slightly a little bit more consistent than the male one, but you can see that in the male one in the 13, 14, 15 years, they get a bit closer. So they're not the same as the first graph that I showed you on this. Why do we age standardise? One age standardised rate is easier to understand, but how do you show 20 age groups, 4 ethnicities, 1,500 types of discharge and demographic areas in a compact way? Well, it's very difficult. And what my suggestion is that the focus of your study will help determine what variables you look at and seek the opinion of subject matter experts. So if you want to do a study on diabetes, talk to doctors, clinicians, health experts that know diabetes. They'll help narrow the fields that you could look at. There's also different statistical procedures that you can undertake which will affect the rates that you compute. And I'm going to touch on some of these now. Choosing a standard population, ethnicity collection, and the choice of a comparator group. The choice of a standard population will affect the rates you produce. If you remember back to the population pyramid, the Māori one is quite young and has a different shape than a non-Māori one. If you choose a standard population with a similar age group to the focus group, your age standardised rates will be similar to the crude rates of the focus group. And because mortality and many conditions are highly correlated with age, an older population will produce a higher age standardised rates and vice versa for a younger population. This little table will help explain that. This is 2013 disability survey data, and at the bottom is Statistics New Zealand crude rates. So these are the rates of the number divided by the population. The number of disabled Māori divided by the number of Māori, 26% of Māori were disabled, 25% European, and 24 total. If you age standardise the data to a young population, the Māori population, you get an age standardised Māori rate of 24%, so that's similar to the 26%, and the non-Māori rate is a lot less. If you look at this, because mortality and the vice versa thing, they standardise in the non-Māori population to a younger one, it creates a a lower rate. If you standardise this data to the WHO population, the Māori rate's 30%, a lot higher than the 26%. If, like I mentioned, an older standard population will produce a higher rate, and the 24%, which is actually the European group, is similar to the European group. The other thing that the choice of numerator and denominator also affects the rate, and I'm just going to talk about some of the things the ministry has done to improve ethnicity data. First of all, we have two tools. We have the ethnicity data protocols and the health equity assessment tool. Ethnicity data protocols are used in the health sector often by hospitals, PHOs, general practice, and they say how to collect ethnicity data. So we try and they are asked to use the Stats New Zealand way of asking the ethnicity question, and it also gives tools of how to, examples and ways of how to present the data. And the health assessment equity tool is a set of questions which the health sector can use to check on ethnicity and to check on inequalities and how their programs will affect inequalities. Both those tools are available online, so if you search those keywords, ethnicity data protocols, health equity tool, you can open them up and read them. Another tool we've used in the past, we're not currently using, but use the Ever Māori approach. And what that means is in different health sectors, people may answer the ethnicity question or it may not be answered. So if they have answered Māori in one data set, we can populate the other data sets with Māori. Another thing that's happened recently is around the COVID immunisation program. About 100,000 people that weren't engaging with the health sector now have, so that's improved our ethnicity data as well. Some indirect things that we're doing, we are now collecting iwi affiliation data, so people can go online and load their iwi, if they're of Māori descent, they can load their iwi affiliation, and this may be of use sometime in the future. We also have Ao Mai Te Rā, which is a anti-racism kaupapa work program. It's designed to look at racism, identify it, and looking at what we should do by getting people that haven't looked at this talking about it. And if you want to see, there's a podcast series as part of this, and if you want to read one, you can go live on YouTube, Ao Mai Te Rā, and you can have a look at that. Standard populations used at the Ministry of Health. So currently the ministry uses a 2001 WHO population, and that's the one in the middle on the table. Before that, we used a SIGI population, which was younger because it's got more people in the young ages and less people in the older ages. And the third one is the 2001 census Māori population, scaled to 100,000. So you can see that it's younger. And so like when you age standardise, an age standardised rate is an artificial rate. So when you look at these low numbers here, when you age standardise the WHO pop, you virtually boost the numbers to be equivalent to this. And so that's why the rates are higher. The comparator group used at the Ministry of Health. Before 2000, way back in the 1970s, not all health sets started to collect ethnicity data, but as it got close to 2000, they did. And the non-Māori group was mostly used as a comparator group. During these periods also, the non-Māori group was used as a comparative group for the Māori by many Māori academics, for example, in the Hauora series. In 2019, we produced 2 reports for the Waitangi Tribunal as data for the health services and outcome inquiry. And in those reports, we used the non-Māori population for some of them, just a small part of them. And since then, the non-Māori, non-Pacific group has become a bit more popular, both in the ministry and outside the ministry. In the ministry's key reporting in the New Zealand Health Survey, Māori are compared to Māori, Pacific are compared to non-Pacific, non-Māori is not used. In the national collection, we generally show rates for Māori, non-Māori males and females, not non-Māori, non-Pacific. Going forward, we have some challenges. The WHO standard population is due to expire soon. In 2018, when we did our last Māori Pacific report, the age structure was older than 2001, but it didn't produce different rates, or not generally different rates than using the 2001 population. But what will the 2003 census bring, and what's changed? We don't know. Also, there's been a reference group set up to consider the reporting methods used by Te Whatu Ora, Te Aka Whai Ora and the ministry, so the Health New Zealand, Māori Health side of the ministry. And this is an opportunity to align all our reporting methods so that we can use one method and not confuse people. And one of the things that's happened is when we age standardised to the Māori population, we produce different rates that are produced that's standardised to an older population like the WHO population. And that can create confusion for the minister who sees different rates for the same things. That's me now. I won't ask for questions in person, but and save a bit of time. And if you want to send me an email or put questions in the Q&A, I can answer them there. Thank you very much.
Kia ora, Peter. Thank you very much for that interesting presentation. I think we might have time for one question if someone wants to ask. And it was really good to hear you mention about the Omatira podcast. I think that's a really good podcast. It's really good to listen to. Do we have one question? No questions, nothing's in the chat.
Ka pai.
Kia ora, Peter. In that case...
Sorry, there is one question from Vladimir.
Oh, cool. Go for it.
Thank you very much. I already sent this. I already put my question into the question and answer panel, so maybe it's quite long, but from my point of view, which is quite common spot, that approach of using age grouping and, for example, ethnicity, it's just a proxy when we want to provide better profiling for our population. And the other answer to these problems and those challenges which we just heard in this talk, and quite really common and so on. So the next step to improve our profiling of entire population is to work with big data, and in particular of joining data from different sources about our population. So the yeah, just maybe a comment, or maybe I would be very much interested to hear the opinion about that. Thank you.
Thanks for letting me. Peter.
For ethnicity is like one way of measuring Māori people. It's not the only way. You can measure them by blood, by their descent, if they claim to have descent. And ethnicity, some people answer ethnicity different in different environments. So like if if you go into a hospital and your son's got a broken leg and they ask you for your ethnicity, you race through all your questions and perhaps not give them as much thought as you did when answering the census. Having said that, the health of Māori people has been hasn't improved a lot over time, and improvement of this ethnicity question or profiling Māori is one of the best ways that I know to help improve Māori rates and health.
Thanks, Peter. Our next presentation is Paul Bingham from MPI, talking about Japanese encephalitis.
Hello, it's very nice to be talking to you today. My name is Paul Bingham. I'm an epidemiologist, principal advisor in animal health surveillance and incursion investigation, working for Biosecurity New Zealand at Upper Hutt. And today I'm going to talk about some aspects of Japanese encephalitis virus, around the virus and competent vectors, its maintenance in populations and transmission, the disease distribution internationally and its significance with some statistics, what happened in Australia this year, and as a result of that, the risk to New Zealand in terms of introduction of JEV and establishment here. And then looking at existing animal health surveillance and some new initiatives. Japanese encephalitis virus originated from its ancestral virus in the Indonesia-Malaysia region and evolved there into the different genotypes we see today, which then spread out across Asia. As the name suggests, a lot of the early work was done in Japan. In the late 1800s, the disease was first described. In the 1920s, it was realized that the disease was spread by a mosquito vector and had a seasonal disease occurrence. In the 1930s, the virus was first isolated from the brain of an encephalitis victim. And in the late 1930s, that the main mosquito vector was confirmed by virus isolation from Culex, Trichinoranchus mosquitoes. And in the late 1950s, the classic transmission cycle was described between viremic birds and pigs and mosquito bites to people. We now know that JEV is a flavivirus, closely related to West Nile and St. Louis encephalitis viruses. There's only a single serotype, but there's 5 known genotypes. Type 4 is the oldest and significant this year because that's the one that's been circulating in Australia. And there's a wide range of competent mosquito vectors, and I've listed some of them over on the right. So Culex Trichinoranchus is the primary vector, but of note there is Culex quinquefasciatus, which is found in New Zealand. JEV, like many other viruses, is a zoonosis, and it's a true One Health candidate with the environment driving mosquito abundance and subsequent infections in animals and in people. Spread to new areas could be from movement of competent infected mosquito populations into those areas, or the movement of viremic vertebral hosts, or pigs or birds, who then infect resident competent vectors. The main amplifying hosts and maintenance hosts are the wading birds, but certainly pigs develop a very significant viremia, and in a commercial setting, pigs can transfer the virus between themselves horizontally as well. The primary method of transmission between hosts, though, is the bite of an infected mosquito. And mosquitoes can also transmit the disease vertically between generations through their eggs. So the main sylvatic cycle is shown here with egrets or herons and pigs being bitten by mosquitoes. And there are a number of dead-end hosts, so mosquitoes can bite people, horses, dogs, cats, cattle, possums, and they will certainly seroconvert. And in the cases of people and horses, clinical disease can occur, but they don't develop a sufficient viremia to then pass the disease on to other mosquitoes. But a number of birds can become viremic and certainly have been proven to do so in an experimental situation, and I've listed some of them there: pigeons, sparrows, blackbirds, etc. But their significance in the epidemiology of disease is not really well understood. Clinical disease generally doesn't occur in infected birds, and the degree of viremia in animals really, as I said, is determined by the species of animal, but also by the strain of virus. JE is probably the leading cause of encephalitis in people in Asia, and it occurs up to around the 45th parallel, so 45 degrees latitude. And depending on the source you read and year on year, there's thought to be around 100,000 clinical cases of disease in humans, with about 25% death rate, depending, as I say, on the source. Most cases, unfortunately, in the endemic areas occur in children, and a high percentage of the survivors are left with permanent neurological or psychological problems. JEB does have a tendency to extend into other geographical areas, and spectacularly in 2022, an outbreak of genotype 4 was detected across a very large geographical area in eastern Australia, resulting in disease in pigs and also local infections to people. Australia, apart from the Cape York Peninsula, had previously been thought free of JEB, and it was thought that the very wet conditions earlier this year resulted in an increase of competent vector species, particularly the ubiquitous Culex annually rostris mosquito, and the virus moved rapidly through the areas, allowing infection of these mosquitoes with the movement of viremic wading birds who were exploiting the new flooded areas. Australia then is an epidemic area, so they're potentially a country with a large immunologically naive population, and so there's risk of Japanese encephalitis across a much wider age group of people. So with the emergence of JEB in southern and eastern Australia, the risk to New Zealand would have increased. By how much is hard to quantify, but if we have a look at the introduction methods and then the chances of establishment, in terms of introduction, an infected, competent mosquito population could arrive in New Zealand by hitchhiking through shipping containers or on ships or on planes. There's precedent for this. There's 3 introduced species in New Zealand already: Aedes australis and nodoscriptus, and Culex quinquefasciatus, and they were all believed to have been introduced through shipping vessels, whaling vessels, then shipping vessels. So that's probably the highest risk method of introduction, or the most likely one. Wind spread is a possibility, probably low risk, although mosquitoes have been found several hundred kilometers off the coast of countries. Or there could be the introduction of a host, a vertebrate host species such as a bat or a bird or a pig. And we do get migratory and vagrant birds from Australia. The picture's showing there egrets, and they migrate here annually. The number, again, driven by conditions in in Australia. They can be viremic for up to a week, but they typically arrive in late autumn, so the vector species would be quite low at that time. So the risk is probably not great. And in terms of viremic pigs or poultry, through importation, New Zealand doesn't import those species, so we can rule that one out. So the most likely pathway would be a new infected competent species of mosquito arriving and establishing itself in New Zealand, or infecting a vertebrate host here through feeding off them and allowing an endemic competent mosquito to then become infected and maintain the virus. So the question really is, has New Zealand got a competent vector? And this table here is a sort of summary really of a study done by Laura Kramer on vector competence of New Zealand mosquitoes from 2011. New Zealand's got 13 endemic species and they looked at 3. The reason that they chose 3 was that these were the most likely mosquitoes of the limited numbers here, or the limited species here, to be potential vectors of arboviruses because of their abundance, their distribution, and their host preferences. They include the 3 introduced species, including Culex quinquefasciatus, which is a known competent vector in other countries, and I actually added the 2 eradicated species at the bottom there. So these were introduced but then eradicated by MPI, including Culex sitiens, of which there's a small population, and that is competent for JE. With Culex quinquefasciatus, you'll note that under flavivirus competence, Japanese encephalitis virus is not there. This is because in the study, they found they could infect the mosquito, but at the temperatures used, which was 24 degrees, it could not complete its intrinsic incubation period. Sorry, it's an extrinsic incubation period to allow transmission to then occur successfully from the mosquito, and certainly flaviviruses replicate faster in warmer weathers. So it was not found to be a particularly competent vector at our temperatures. That, of course, could change with increasing temperatures over time with global warming. They did find, however, that the virus could overwinter in Culex mosquito eggs. So looking at surveillance, existing and new initiatives, as discussed, the highest level of risk is probably at the border around introduction of infected mosquitoes. And the aim of surveillance at the border would be to detect those introductions and allow us to stop establishment. I'm not really going to talk about that surveillance because Lora Peacock, one of my colleagues, has got a couple of talks down, and she'll be covering those areas and new initiatives there. But in the post-border space, we've got existing passive surveillance and some new initiatives around active surveillance. The aim there in the post-border space is to detect a JEV if it's circulating, so if it's already established, and evidence of absence if it's not. So the passive component that's already in place is in species that could show clinical signs. So the 0800 number, veterinarians can ring that if they see reproductive issues in pigs or neurological issues in horses, and then we can test those animals through molecular and serological methods. The new initiatives are serological. So we were looking at animals that can seroconvert. So resident birds, particularly ducks in the warmer areas. We were looking at bird rehabilitation centres, and cattle. We already have quite an extensive arbovirus surveillance program where we take sera from hundreds of cattle every year in risk areas, and that includes areas where the migratory species of birds do come, and also the warmer regions. So we're adding on to that program the flaviviruses along with the existing arbovirus serology we're doing. The next best candidates would be domestic pigs or dogs, but at the moment we're not doing those. Don't think the level of risk really warrants it, and then the pigs are covered really by the passive surveillance system. But we could always move into that area if the degree of risk became greater, or in a response situation where we've already made a detection. So this map shows the geographical coverage of serological surveillance from the cattle. And as I said, it covers the warmer areas, including the main arrival sites for the migrants. At present, the risk is probably low from introduction this way and establishment. But this could change, as I say, over time. And we are also extending this program into some sites in the west coast of the South Island where some of these migratory birds do arrive in that area. Right, and that's about it from me. So thank you very much for the opportunity today, and I'll hand back to the conveners. Thank you very much.
Thanks, Paul. That was a great presentation, and it definitely highlights some of the issues that we're all facing, including the effects that climate change will have on communicable diseases and those vectors which have previously not been found in New Zealand. It also highlights the importance that some of our health protection officers and medical officers of health colleagues do, as one of their responsibilities is to monitor the points of entry, so airports, ship ports, and those transition facilities for mosquitoes, which is something which not a lot of people realise. Of course, if anyone's got any questions for Paul, just put them in the Q&A, and we'll get them to Paul to answer. And yeah, that would be great. We've now got a bit of a change in our agenda. Dr. Jonathan Watts was scheduled to speak, but this has been changed to Professor Shanthi Ameratunga from County Manukau District Health Board and the University of Auckland. So if you're online.
Kia ora koutou, karara sama mihinu kia koutou, ko Shanthi Ameratunga toku ingoma, norela tēnā koutou, kia ora mai tātou katoa. I'm just going to share my screen. Hopefully you can see this. And I really appreciate the opportunity to gate crash your party. I've been really listening to the presentations the last couple of weeks, and I'm an epidemiologist by background and a pediatrician, and I was really conscious of how amazing some of the tools, models, statistics, and modeling that you're presenting. And some of the learnings for me as a quantitative researcher who's now much more interested in qualitative research has really been how data can deceive us. And some of this has already been reflected by the presentations today. And actually, Melissa McLeod's presentation in particular was, to me, quite inspiring from last time. I'm going to talk about a particular case study where we're going to look at streetscapes and the nexus between transport and health, especially in relation to what we see and what we don't see in relation to disabled people, tangata whaikaha, and older citizens. This is the kind of data that I was immersed in as an epidemiologist and injury epidemiologist in particular, quite heartening looking figures here of the admission rates for pedestrian injuries by age group. In red is the older people. In blue, tracking in the middle but going down very reassuringly, it seemed like, is the pedestrian hospitalization rates for children, which is an area that I was particularly interested in. If you think about what this is showing, though, these are rates. The denominator is the number of people in the population of that age group. More and more children, however, in the same period were walking less and less because they were getting bundled into cars and being driven around. That we know that children's travel prevalence was dropping precipitously, active travel. So what we were looking at here for me was actually no longer that reassuring, because you have to be a pedestrian to be a pedestrian injury. And this is not the kind of finding that should give us that much reassurance. Of course, knowing that children in poorer environments, low socioeconomic environments, as well as adults, actually are more likely to be pedestrians means pedestrian rates in the high deprivation indices are going to be much higher. Anyway, this was not just a wake-up call, but an awareness-raising issue for me about what we do and don't see with data. The other aspect that I was really conscious of and interested in was active travel, because of all the benefits that we know from first presentation onwards of reducing fossil fuel consumption and the physical benefits and climate change benefits. But the sort of posters we were seeing gave an impression of quite an interesting demographic of people who can cycle, walk, run around, do really active things. And I was talking with one of my colleagues, Dr. Annika Anderson, who's a Maori medical anthropologist, who has been working alongside in another project on access to healthcare, and particularly in a study looking at Te Puia Memorial Marae, which is in South Auckland in Mangere. And she was saying actually many of the issues she was hearing about related to access to transport, access to ability to get to healthcare. So this led to a project that was funded by the Health Research Council and involved these wonderful collaborators that I want to acknowledge, and in particular Annika and Bridget Burdett, who's actually a transport engineer, and Fire Dolly and Fire Julie, who were our kaumatua for this project. I'm going to very quickly go through what we found in this study that I think basically are useful as a signal for what my title was. The questions that prompted us, and the first one's the most important: how do our transport systems influence opportunities for social participation, health and well-being of tangata whaikaha and older people in Tāmaki Makaurau? It was interesting for us to also check, well, how do our monitoring systems actually reflect their lived experience? And how do transport professionals perceive their practices in relation to these realities? We did quite a complex project, which involved engaging with communities, engaging with transport professionals, and looking at the measures, audits, and indicators they're using. I'm going to focus mostly on the first strand, which is the community strand, which was a strand of 4 case study sites across Tāmaki Makaurau, West Auckland, Gleninas, Panmure, Mangere, particularly around Te Puia Marae, and Hawick, Pakuranga. We undertook 62 go-along interviews. Those are qualitative interviews where a researcher accompanies a participant who's either disabled or older, or both. A third of those participants were Maori, a third were Pacific, a third were Pakeha or Chinese, largely from the Hawick site. And these interviews were conducted by community people, research assistants from their communities, speaking 9 different languages, so that people had a better chance of engaging in the korero. There were 8 interactive community workshops. You can see a picture of what some of those workshops looked like. They were incredibly energetic, lively, engaged events. I want to mostly focus on this particular experience from Mangere, the case study that we talk of. Now, any of you who visited Auckland or live in Auckland and have gone from the airport to the city centre would have taken the Southwestern Motorway, which basically is State Highway 20, cuts across from the, gets the shortest route effectively from the airport to the city. But what you can see here is, I don't know whether you can see my cursor, but the motorway cuts Te Puia Marae Memorial, the Marai's access to everything on the other side, which is where the health center is, where the Urupai, the Moana, effectively, they were cut off in 1980. And as they said, we were all right. These are the kaumatua in Te Puia Marae. We were all right until the motorway came. That changed the whole dimension of where you sit in Mangere Bridge. Because effectively, what was happening was those infrastructural decisions that were made have really had impacts right to now, which is basically when relatively recent that we did this study. And the intergenerational impacts are tragic, actually incredibly sad to hear, and very, very disturbing. And basically, this is the motorway we drive on. And on the side here is the walkway. People are supposed to walk to avoid it. You can see how dangerous this looks. There's obviously vehicles crashing into the bars on the side. After the fact, they built a bridge to basically get people across, but that's really at the top end there. Basically, it's a daunting thing to even think about walking up to that bridge to cross across the motorway. And even 40 years later, this is a road closed sign for where the motorway cut across, and ambulances get lost getting to this marae. As they said, it's been cut off. The Mirror Road has been cut off. That's the main access to go to the other side. They don't know that we even exist on this side. 40 years later. The cultural impacts, the Kaumatu were cut off from their tupuna, access to Urupa, Moana, and they can no longer harvest the harakeke. It's a terribly polluted, environmentally polluted area now because of the motorway. And as this Koya told us, I know I wasn't the only one that was stressed that a motorway was going to cut us off from the marae and to what we said the Urupa. It has impact on children and their children, the Tamaraki who used to visit this marae. The marae is, one of the fire told us, the marae is there, supposed to be there for our whānau, but the motorway stopped the kids coming because the parents come first. They come down here to nurture the marae, but they don't because the kids have nowhere to go. It's really not safe for them. So what happens over the years, it takes away the tikanga. This is one Kaumatu Akoya who told us about what it was like for her. She was a older lady in her 70s, required a carer to come and help her. She had no access to a vehicle. In fact, none of the Kaumatu up Byron 1 had access to a vehicle. And she was quite substantially disabled, but had a real joy for getting out. She said, I'd like to make a lot of journeys like other people, but there's no buses, no way out. Some people not like me. They walk up to, because they're capable of walking up to the bridge, catch a bus, go all over, wherever the pension card takes you. And if you're not capable of doing that, then it's look outside the window. Yeah, see the big world then. Hello, here I am. That kind of isolation and community severance was incredibly common in the stories we were hearing from the Kaumatu in Te Puia Marae. It was I'm going to just very quickly talk about the couple of other sites. This is Howick, and it was really interesting to hear or see what power and privilege confers. This group was both the oldest of the interviewees, but also the healthiest of the 4 sites, high levels of education, computer literacy systems knowledge. They basically were often professionals who had retired and were very actively engaged in probus groups and open university and everything else. It translated to a lot of confidence in navigating the systems, even when there were problems, and advocating for themselves. So Barbara was a lady, again, in her 70s. She used her iPad to map her journey. She loved getting around by bus, and because she knew it was the healthy thing to do. Anyway, she'd gone for a ride. She said when she came off, she came to her stop. She rang the bell. The bus wasn't stopping. She said, I want to stop there. And the driver went another 10 or more meters up the road. And I said, the bus stops back there. As I got off the bus, he said, the driver, fussy old lady. I said, I heard that, came storming home, sent off a complaint, got a reply back the next day, which is most unusual for Auckland Transport, saying, we will interview the driver, and if necessary, he will be sent off to more customer service training. Now, however good that particular intervention might be, what was very striking was how commonly people from this site were shooting off complaints through their iPads, through the internet, through the websites, whatever places Auckland Transport has the complaint sites in. Now, it is almost interesting to think, well, it's just all about socioeconomic status, but Glen Innes was an interesting place where the School of Population Health used to be. It's a low-income area, culturally diverse, rapidly getting gentrified, I might add. But it has a very interesting transport scenario because there's a train station right next to the community village, and there is a bus hub. So it provides, even in the context of relatively low access from a financial point of view, people to actually engaged with the community, and that made a real difference to the Maori and Pacifica communities we were interviewing. They said that while they were the youngest, they also had a lot of comorbidities in this community, the interviewers. But they expressed a love and care for GI, its shops, community, and environment. And as someone was very obvious even in the community workshops that we're doing, this is Mario, who's a young Pacific man who needed, who actually had a life-transforming scenario when his district nurse managed to get him an electric wheelchair, which took about 2 years, but he got it in the end. But he says, you know, even if I get to go out, my spirit already lifts up, distracts me from the pain. He's in very significant chronic pain. So you're doing things that distract you from your suffering. And if you are mobile, it's easier than reading books. That is why I like going out, get more distraction from not suffering. So, I mean, it's interesting to see how it was not just a simple issue of ethnicity or socioeconomic status, the actual infrastructure and urban planning matters. Now, I'm going to very briefly mention a few quotes from our transport planners. They are just like health service planners. None of us wake up in the morning saying, today we're going to go increase inequities. It is what we do, but these guys don't do it any more intentionally than we do. So this is one of the comments. I think most people who work in this field are aware of the need and benefits of facilities that improve accessibility, but priorities still tend to be set with the primary focus being capacity for motor vehicles. Probably not surprising to any of you. Transport engineers generally have good knowledge and modes of transport and associated safety. Now, you might get a bit challenged by this. It is economists, asset managers, and grumpy old men that hold the cash who don't understand and consider it a priority. And last but not least, this is really important, I think. Most designers are able-bodied and drive everywhere. So just telling them that it sucks for people in wheelchairs isn't going to have much meaning. Now, there's a couple of issues that come up with data as well. So for road safety, as I pointed out before in my first slide, we have the road tolls, we have hospitalizations, they can be deceptive, but we are counting those numbers very interesting, with a lot of interest, and we track those numbers. There is nothing that we're looking at in terms of regular data for inclusive mobility. There is no way that we can see the trips not made. The Kuya and the Kaumatua who were talking about not being able to get out. How would we know? I get asked because I take the bus and train to work at Middlemore Hospital. When I'm on the train, I get every once in a while people coming over and saying, can you please fill out this survey? I almost always ask them for 2 forms and give one back slashed across saying, but I'm on the train. You didn't ask the right person who didn't get here. But I do fill out the form just to be civically minded. But it is really interesting how we collect information on who's experiencing hardships or inequities by talking to the people who've already got the privilege of getting on the train or the bus. And also setting up systems of complaint making that is certainly privileging a certain demographic and not others. So these are outcome measures that are influencing transport policy planning, design, and construction, and they're heavily biased towards privilege. So what have we learned? I think one thing that's pretty obvious is when we design infrastructure, what we privilege for some may have devastating consequences for others. Our infrastructure very powerfully impacts physical and social well-being, and it manifests in unequal ways across communities, strongly patterned by power and privilege. Next time you take a bus, well, you probably won't be taking a bus because there's not too many buses. They stopped the airport bus, which is very unfortunate. But you take a shuttle, a car, or taxi across to the city center from Auckland Hospital, from Auckland Airport rather. Just put your thing down and say, who actually is out of sight, out of mind here? When it's whizzing through and we've got the best option to get across as soon as possible, there's a group of people who have basically paid with their backs, and they protested vehemently 40 years ago, who were not heard. The importance of reaching communities to engage on their terms is obviously crucially important. And our consultation processes and professional practices often reproduce the inequities that we are theoretically trying to address. So as I mentioned, think about the people who are ignored when you take the motorway next. Think about who complains and who doesn't. Those are often data that we use. Think about who are we consulting with? How do we measure trips not made? And there are other things like that in terms of health service user populations and what implications there are for immunization rollouts and vaccine rollouts, how useful and acutely sensitive is our data to address inequities. And what does fertility mean for us personally and in our day jobs? To what extent do we employ equity-focused decolonizing methodologies to monitor how we're doing? As we heard from these communities, they want people to come and talk to them. They're not hard to reach, quote unquote. They're willing to talk and keen to engage, but they're often not engaged. Just want to end with acknowledging the amazing participants, several of whom have passed on now, and they have sent a very strong message not to forget them. And I hope that our work going forwards will reflect that. Acknowledging the Health Research Council and my email and 3 publications that you can look at.
Kia ora, Shanthi and Kapai for that presentation. It was really eye-opening. And I think it highlights the importance that public health has in urban design. We'll open the floor to questions now. I'm sure there'll be a few down there somewhere. Is there any questions coming through there, Patrick?
No, I'm not seeing any.
I have one then. We can start off there, Shanthi. In terms of the role for people in the health industry, what can we do to maybe help resolve some of these issues that you've highlighted?
Thank you, Tim. I think it's a question actually asked Ashley, I think, and I know that he referred to this. I think we need to learn to work across sectors, obviously. And the transport people are not just geeks. I mean, I did think they were to begin with, but I actually have many more presentations to transport and traffic engineers these days than I do to health people, because I know they're the ones who I have to influence. They're the ones who have to hear this, and they're human beings. They don't want to make this stuff happen as a routine. And I think I learned a lot, an enormous amount, from actually understanding what their day-to-day job is. So I think in answering your question, I think part of this is about becoming comfortable ourselves in understanding not just data, but how to communicate data and how data is visualized and conceptualized across sectors. And I think whether it's transport and health or transport and education or transport and justice, the cross-sector work I think is phenomenally important. I worry that often health works within health and transport people tend to do they have their own jargon and they speak another language sometimes. But yeah, it's to me hugely exciting and enabling to cross some boundaries. I'm a migrant, obviously. I'm from Sri Lanka, and I've had to do this all my life and also work across disciplines. It's the most exciting place to be at an edge, be at a crossroad and see, oh my goodness, no wonder we're missing the plot here. We're talking past each other. But if we're doing that across sectors, imagine what we're doing with our communities. And the reality that most of the communities we're engaging with are more people like us. They're not the people we need to hear from. So it's a big question, Tim, but my sense is it's about communication and humility and openness and acknowledging, yes, we have subject matter expertise, but not in every area. We have to recognize who has the lived experience.
Yep, nicely said. A follow-up question, there's been a big push, not only from local government, but also central government for this development of sort of cycle-friendly pathways. Do you see that benefiting accessibility as well?
It's a really challenging one, Tim. I think I'm a very strong, I'm not a cyclist, not that I can't cycle, but I'm actually almost a conscientious objector, only because I keep thinking sometimes you get on a cycle, you forget the people who can't cycle. And so I think the conversations that are arising around cycle infrastructure and interventions are very important, extremely important to move us from a car-dependent society. But there's somewhat of an invidious challenge being set up, almost a competition between cyclists and people using mobility aids and pedestrians and children. And what's happening though is we're all fighting for the margin. we should just get rid of those cars and have much bigger areas on the side and let the cars have the margins so that we don't argue with each other on whose right of way is it. And I think it's a very unfortunate debate, sometimes very angry one, between disabled people and cyclists. But I think it's mostly because we're actually all fighting for attention at the margins.
Yep, no, well said, thank you. I saw some thumbs up there, so I think you've got some agreement as well. Thank you very much for that presentation, Shanthi. Our next presentation is Masako Wada from MPI, talking about climate disease model using AI. Masako, the floor is yours.
Hello, everyone. I'm going to share the screen. Is this the right screen?
We can see it, but we can also see your notes as well. Yep, that's it.
Yep. Okay. So I'm Masako Wada. I'm a research officer in veterinary epidemiology at Epicenter Massey University. So my talk was supposed to be a continuation from John Watt's talk. He was going to talk about EARS, early aberration reporting system. So I work with him to develop EARS, and this is going to be an extension of EARS, climate disease modeling using artificial intelligence. So EARS uses the approach of syndromic surveillance. So this is about using making use of a secondary health data for early detection of disease outbreaks. So, and there is strength and weakness in this method. The strength is timeliness and low cost of obtaining the data and wide coverage of diseases. The weakness is in the low specificity of the system and the noise of the data. So this timeline on the right is showing the potential data sources for waterborne disease outbreaks. And from exposure to first diagnosis and when the disease starts to become severe. EARS uses laboratory test orders. So the diagnostic labs, they have the submission forms, and MPI collects these data and the information is stored in the system. And what we're trying to do here is to add climate data, which is more closer to the exposure event for some diseases. And we are trying to improve the timeliness and specificity of the system. So the objective of this project is to develop a system that supports early detection and forecasting of climate-sensitive disease outbreaks. So this project combines three relatively new areas of research: syndromic surveillance, climate change, and AI. So what we will do is to develop a system where animal surveillance data and climate data are collected, and that where climate disease AI models are trained, and the performance improves as more data becomes available. So I put the pictures of Tesla here. Tesla is a self-driving car, and it has an autopilot, and it becomes smarter and smarter. It has AI models, and they get trained in the supercomputers called Dojo. So they have the massive video data, and the more data becomes available, the models can learn better. So why we are interested in climate change? Climate change is affecting us in many different ways, including disease distribution. And as in Paul's presentation before, Japanese encephalitis in Australia is the most recent example. So it happened at the same time when there was an extreme flood in that area, and that provided the suitable environments for water birds and mosquitoes, which are the spreader and amplifiers of the virus. So previously, my colleague Emily Mountier and I worked on a project to look at the impacts of climate change on New Zealand livestock. And we reviewed over 1,000 of published papers and to look for an evidence that climate is affecting diseases. So I put the bar plots here from the reports. It's showing the number of articles that are demonstrating the relationships between each disease and rainfall and temperature. What we found is that many diseases that are climate sensitive are parasitic or vector-borne, which means many are zoonotic. And I put the stars here for the diseases that can infect humans. And we can see many diseases with public health importance, like salmonella, crypto, and lepto, and so on. And as a case study, we developed a disease climate model for facial eczema. Facial eczema is a fungal disease of livestock caused by toxin produced by fungal spores in the grass. And this fungus grows in dead pasture litter in the warm, moist conditions. So we thought that the amount of spore is affected by temperature and rainfall. We collected 7 years of spore counts data from the local vets in the North Island and the climate data in the matching location from NIWA. And it was a challenging thing to develop a model because the data was quite noisy and there were over 500 climate variables to consider the historical climate data, and they are intercorrelated with each other. So we considered two approaches, linear regression and random forest. Linear regression is a standard statistical approach, and we struggled with this one. It required good prior knowledge, but we didn't know which variables would affect, and we didn't know about the interaction. And the resulting model had a poor fit. Random forest is a machine learning method. It's a data-driven approach, so it requires no prior knowledge from us. And it demonstrated to be quite good. It had over 80% of accuracy in classifying high or low spore counts. And this plot here is showing the variance importance. It's showing which variable affected the spore counts for facial eczema. And this result was quite surprising for us in a good way. So it showed that Earth's temperature and solar radiation, which is the sunlight, for months before sampling affected spore counts. And rainfall, which we thought was a risk factor, wasn't really influencing the spore counts. So this was a positive experience for us to transit from the traditional statistical methods to more modern approach using AI. AI is a broad term meaning computers programmed to mimic human intelligence. AI includes machine learning, which includes neural network, which includes deep learning. The more advanced it is, it's closer to how human brain functions. So AI in medical fields, AI is starting to be applied in diagnostics, but it's not widely used in epidemiology yet. And Blue Dot is an initiative effort. It's a Canadian project meant to detect biothreat like SARS outbreaks. It scans wide range of data from scientific articles, 300,000 per day, and global media of 65 languages to detect biothreats. They claim that they were the first one to detect the early signs of COVID outbreaks in the late 2019. The specificity of the system may be low. They do have a team of epidemiologists to review and interpret the outcome. So what we are doing with MPI is to establish a system where the data are collected, the animal surveillance data, which comes from animals to the labs and then to MPI. And we already have the reports to see the trend where the disease is happening, and it has some levels of alert. And recently, we have added an automatic import of NIWA climate data. This is the monthly summary data, and it comes to MPI database. And what we are doing, we are in the process of adding climate disease model. So far, we just have a random forest model. But with this, we may be able to detect climate-sensitive diseases earlier. And we also need to add some system to evaluate the sensitivity and specificity of the model performance, and for the models to self-learn for better performance. So I will show you an example here. This is the front page of ears, and from there we can navigate to add a report that is the climate disease random forest model. And here I am choosing bovine diarrhea with all available climate variables. There are 16 of them. And as a background information, so we know when diarrhea happens more often, like around August and September. And we could also see the long-term trend. Okay. So the number of cases are slightly increasing over time. So the model runs, and after a few minutes or so, it shows the outputs. So here it's showing, the bar plots on the left is showing which variable was important in the case, the number of cases of diarrhea in that district. So we could see that soil moisture deficit in November was highly associated with the cases of diarrhea. And we could also see some other conditions in November are important for bovine diarrhea, it doesn't mean that these variables cause diarrhea. It may mean a lot of things like grass nutrition, or animals eat other plants that may be toxic. We don't know, and we need more investigation. And the plot on the right, the scatter plot, shows how well the model performed. If the dots lie on the straight line, the red line, it means the model performed well. It means the predicted value is close to observed values. So the model was reasonably good. It had a correlation efficient, very close to 1 for training data and testing data. So to summarize, it is challenging to model climate disease relationships because of the uncertainty in the way climate affects diseases. We don't know which variables affect disease, in what way, for which time period, and those interactions. It's very complicated. But we see some potential in the use of AI. It's more suitable than the conventional methods, and AI can do what beyond what human brains can do. The future work include adding other AI algorithms. For now, there's just random forests, but there are many of them, and we need to validate these models. And eventually, we want to implement this in years to have it in operation to monitor and predict climate-sensitive disease outbreaks. Lastly, I want to acknowledge my colleagues and collaborators for the support of this project. Thank you for listening.
Bye. Thank you very much, Masako. It's really interesting, and I think it's definitely the way of the future, isn't it? We've got some time for questions, so we'll open the floor for questions. Maybe I can start with Masako. Is ears open to the public? Are we able to access it, or is it locked?
For now, it's only for the MPI surveillance and investigation team, and those who are interested have the access. I'm not sure about the public access, but whoever have an access can see those models and run it even.
Masako, Barry speaking. Can you hear me?
Yes, hi Barry.
Hi, how are you? Thank you for that. Great presentation. Is that the same ears that actually came across that CDC did some years ago? Early aberration detection system? Is that the same principle that they used?
Yes,
Yeah.
that's where we got the idea, and we started developing it about 2-3 years ago.
Yep. Good. Yep. I was in when they started developing ears some time ago, which probably shows you how old I am.
You mean how experienced you are, Barry?
Yeah, been around a while. No, good presentation. I think the interesting thing about that is that the application came from using it for communicable diseases in the US, and I think it's great that you have applied that to, you know, the animal area. And I do recall, I think that ESR used ears for some of their tracking for a while. I don't know whether they still do, but yeah, well done. Good work.
Thank you.
Thanks, Barry. Peter, you've got a question.
Thank you, Masako. I'm just interested to know how the animal data gets into the lab. So, like, do farmers do monthly returns or the yearly returns, or do you go out into the field and do inspections?
This is comes from farms that have sick animals, they call vets, and the vets examine the animals, and they might not send samples, but when they do send samples to the diagnostic labs, then that creates the data.
Thank you.
Great. Well, thank you very much for that presentation. Our next presentation is Dr. Lora Peacock from MPI, talking about reprioritization of surveillance. So if you're online, Laura, the floor is all yours.
Yep, can you hear me?
Yes.
Yep, yep.
Can't see you though.
I'm trying to, I'll just share that. I'm trying to get my video to go. Sorry, everybody.
It's all good. It's Friday. There should be a button down your bottom left-hand screen. There we go.
Oh, yep, I'm there. Okay, now the next step's to share it.
Perfect. We have a picture of a dog. A very happy looking dog.
Right, can everyone see that?
Yes, Laura, that's on the screen now.
Okay, awesome. Good morning, everybody. I'm Lora Peacock. I conduct surveillance for invasive ants, mosquitoes, and arboviruses for biosecurity in New Zealand, MPI. So I'm going to talk to you about prioritisation of surveillance. This is the New Zealand biosecurity system. The system is porous with slippage at each level of management intervention. If we were to have zero risk, then trade would need to stop. And of course, that is politically and publicly probably not acceptable. The system starts with offshore, outside the border to manage risks with international standards, phytosanitary standards, regulations, offshore horizon scanning and of emerging risks and risk analysis and audits and treatments. When you get to the border, there is pathway profiling, there's inspections of cargo, mail and passengers, transitional facility audits, and surveillance is key to picking up the border slippage because not everything can be inspected or screened due to stochastic events, things like that. At the post border, there is preparedness for responses, and of course, responses are supported by the surveillance function. And if everything goes to custard, then there is a recovery and pest management function for containment and mitigation of impacts of that pest or disease. How does the surveillance support the biosecurity system? Through early detection of exotic pests and diseases, and helps to facilitate trade by providing information around prevalence of pests and diseases within New Zealand, and also informing the biosecurity system. The national program, the National Salt Marsh Surveillance Program, it was created in because of the 80s Camp Derinctus response in 1998, the southern salt marsh mosquito. The program was designed to maintain the investment in the eradication. It cost approximately $70 million by focusing on salt marsh habitat to prevent reinvasion, as there was no clear reason for the arrival or spread to other parts of New Zealand. Aedes Camp Derinctus was eradicated in 2010. The purpose of the salt marsh surveillance program is for early detection of exotic salt marsh mosquito species or life stages. It also helps to identify change in distribution of the introduced mosquito species in New Zealand and provide information around endemics, and helps to monitor vector-based risks that are mainly in salt marsh habitat, and helps to provide evidence to demonstrate freedom. and helps meet reporting requirements. And New Zealand does pride itself on the absence of many vector-borne diseases, but however, many people can acquire vector-borne disease from travelling overseas. The most important aspect of the surveillance design is early detection. The surveillance program needs to be designed to detect a population at a level that can be eradicated. As illustrated in this very theoretical diagram of the invasion continuum management curve for invasive alien species, this is mainly used for decision frameworks around management and eradication. But it's important that the detection occurs where the population is low and not so widespread in the proactive phase. The sampling methodology for the Southern Silk Moth surveillance program consists of larval dipping, which is the most sensitive method, with field officers being highly knowledgeable about mosquito ecology, knowing where to look and have a rapport with each site to understand its seasonality. For adult mosquitoes, light trapping is used with green LED, octanol and carbon dioxide attractants, lures that mimic the scent of people from adult mosquitoes. The program is dynamic, responding to innovation in climatic events. A statistical algorithm based on Bayesian probability is used to allocate surveillance hours or effort for each site, and that's based on the habitat size and quality, and closest to urban centre and ports. Well, what are the drivers for change? Curlexidians, and Paul mentioned this in his talk, is a Brachyss species, and it's not a true salt moth mosquito species, was detected with about 4 larvae in Kaipara Harbour. Whilst we thought this was a great find, it was pointed out that this was not really a target species. It's more of a Brachyss species. And as Paul Bingham in his talk mentioned, also the range extension of, for example, other arboviruses, and in particular Japanese encephalitis virus in Australia, has made New Zealand consider, is the biosecurity system meeting that risk? Also, with climate change, the Intergovernmental Panel on Climate Change have predicted vectors to increase their ranges to higher latitudes and altitudes. New Zealand cannot rely on its temperate climate as a barrier to subtropical and tropical vectors establishing under climate change. And of course, there is trade. Trade is increasing globally. It is dynamic and a complex and unpredictable system. Part of the prioritization was to undertake a qualitative-based pathway analysis to understand the pathways better. We looked at mosquito interception data from the New Zealand Biosecure Entomology Laboratory in Wellington, and we found that high levels, with no surprise, occur at airport and seaports. Ministry of Health undertake formalised port surveillance there. However, there has been a number of detections at transit facilities, which are devanning sites for containers, with roughly approximately 0.5% contamination rate per annum. But not only that, approximately 99% of the transit facilities, in total 3,900, lie within 6 kilometres of natural groundwater habitat. And there's no formal surveillance at transit facilities. And I won't go into the bias of the data there, it's just to show the interception rates. The graph on the left shows container numbers received at transit facilities, reflecting the global trend of increasing container numbers globally. You can see from there, you can actually see the impact or effect of COVID and issues with the global supply chains from 2020 to 2021. How should prioritization occur? Originally, we considered a pathway analysis of mosquitoes on Ministry of Health and MPI's unwanted list. But this would take a long time given the complexity of the mosquito ecology. For example, the plasticity of new species, utilising novel habitat and overwintering regimes. We thought about conducting surveillance at transit facilities. However, the map above shows that there are quite a lot. Here is the current status in relation to transit facilities at ports. So the green there you see is the salt marsh surveillance sites, and the red dots are the where the transit facilities are located around the North Island. Similarly for the South Island there. However, the sites at transit facilities are complex with issues around access and health and safety requirements such as safety inductions, PPE. They are dangerous places with a number of deaths occurring, in particular at ports of Auckland, which is a transitional facility. Ports are counted as transit facilities. Site sanitation is covered under the standard operating manuals of each transit facility, and each site is audited by MPI. They also have trained authorised persons to report any an biosecurity risk. However, on the right-hand side of the picture, what is outside the site is of most concern. As you can see, there's wind-blown rubbish and areas where water can pool, but no one looks there. The manuals, standard operating manuals were recently updated to include advice around site management for mosquitoes. It would be unsustainable to conduct surveillance at all transit facilities as the price would quadruple. Thus, a GIS tool was built to see spatially where the risk presented itself. The dashboard shows layers of wetland, transit facilities and current surveillance sites. And we can filter each transit facility to look at flight risk from various wetland habitats based on a meta-analysis by Verdun, Schott and Bessie Skaya 2014 from Limnologica. And here is a snapshot. It's quite it's not dynamic, it's not in real time, but here's a snapshot of some of the results in Auckland from the dashboard. The blue dots are salt marsh surveillance, and the orange squares are transit facilities. The green there is wetlands, wetland layer. We can click on each point and get attribute data for each transit facility, proximity to the nearest wetland, the size of the wetland that it's close to, and the address, etc. And here, similarly, is the lake exposure dashboard with a snapshot of results. You can see clearly that there is no surveillance in freshwater areas. There is no surveillance near freshwater areas at all. This is a nationwide issue. There is a risk of freshwater mosquitoes established in New Zealand. For example, the freshwater ground pool breeding mosquito, Culex annulosarus, which is a significant feature of JEV in Australia and could easily establish in New Zealand. We have also considered adding in a JE factor into the program into prioritisation of conducting surveillance close to commercial piggeries, as pigs are the amplifying host, as Paul Bingham had discussed in his talk previously. And almost there, where to from here? We are currently analysing the data via desktop tools, but there are two phases to the priorisations, and we need to implement this operationally. Phase one is to assess all new natural groundwater habitat within 6 kilometres of transit facilities, ports and piggeries. And phase two will identify and extend all non-discrete salt marsh surveillance sites that have contiguous transitional brackish and freshwater present. All sites will need to be ground truth visited and assessed and allocated surveillance effort hours. And that was quite quick. Thank you very much. Thank you for your attention. I'm well aware that lunch is close by. So thank you all.
Thank you, Laura. Excuse me. Thank you for that. That was another interesting presentation from our colleagues at MPI. Any questions for Laura? Doesn't seem to be any, Laura.
Oh, that's good news.
Well, no, it's probably not great news because it means that they're saving them up for some other time, perhaps. If people do have a question, can they send it to you, or they can put it through the chat? Is that fine for you? So just a question from me then, the reprioritising surveillance. Just to recap, what's the process that you go through to do that? You know, you've got a certain things. If a new issue comes up that you want to put on surveillance, how do you put that into the mix that you're doing?
Well, first of all, we have to technically justify the prioritisation. Is it technically appropriate for what we do? And then whether it's technically appropriate, and then we need to consider the operational application, whether it's appropriate technically and appropriate operationally for the program.
Good, because one of the things that I think in health certainly is that we have an awful lot of surveillance programs. Whether they're actually, it's kind of like they're set up at the whim of somebody. We must put this condition, this thing under surveillance because we've got a system. And so I think we've got a proliferation of surveillance systems, almost like it feels good to have a surveillance system. From what you're saying, that you've actually got a prioritisation criteria.
Yes, yeah, we do. Yeah, just looking at data within the GIS dashboard, we're currently all these programs cost taxpayers money, and that's why they need to be technically justified and appropriate, that they'll work. That the goal for this program is for early detection, and we want to be able to detect at a level that's eradicatable. So that's the important goal, and so we've got the program. We've written business cases to bid for funding to actually conduct the prioritisation with the new operational work. I think we're adding on an extra 10,000 kilometres of travelling to get to each new site. A lot of work's been done using GIS tools, but for these types of programs, you need to be on the ground in the field to understand the habitat and the ecology.
Good, thank you. Any other? I see lots of synergies between what you do in MPI and in the health system with the tools and techniques. I think we can work together collaboratively here to increase our surveillance of both areas.
Yes, there's lots of opportunities to work together. Ministry of Health do port surveillance, and we're more focused in the post-border. So just collaborating with those two types of system.
Good, thank you. Look forward to that. Any other questions from anybody? Comments?
Yeah, I'm happy to answer chat, and people can contact me via MPI. I didn't put my email up, but it's lora.peacock@mpi.gov.nz.
Okay, we'll put that on the PHONZ website as well, so people can contact you. Okay, everyone. Well, that brings us to the conclusion of this morning's excellent morning session. We've now got a break until 12:40. Thank you all for your attendance. Thank you once again to the excellent presenters, and we look forward to meeting you all again this afternoon at 12:40 when we start again with another interesting group of presenters. So thank you.
When you are.
Okay. Kia ora koutou, ko Ruth Cunningham tōku ingoa. Nau mai haere mai ki te hui PHONZ, ki te ahi ei. We have a really interesting lineup of speakers this afternoon. And thank you for staying with us for our final afternoon of this virtual hui. Our first speaker today is, as you can see, Vic Duoba from the Health Quality and Safety Commission, talking about COVID-19 death rates comparing between ethnic groups. I'll hand over to you, Vic. Vic online? Oh.
Okay, can you hear me okay now?
Kia ora, we can, Vic, yep.
Yeah. Okay, thank you. I tend to get these technological details wrong. So, okay, yeah, I'm Vic Duoba, and I'm a senior data analyst with the Health Quality and Safety Commission. I haven't been there very long. Before I go any further, I'd like to just recite a short karakia. Kia hora te marino, kia whakapapa punamu te moana. Hei hurahi mā tātu I te rangi nei. Aroha atu, aroha mai. Tātu I a tātu katoa. It's a karakia that calls for love, peace and respect between people. Okay, so why am I talking about comparing COVID-19 death rates? I'd only been in the commission a couple of weeks when somebody sent around an email with an attachment, and this took me to a CocoNet article, and it was entitled, "Why are Pacifica dying from COVID more than everyone else?" Pacifica account for nearly half, 43.4% of COVID deaths per 100,000 people since the Omicron outbreak began. So this article was by Marina Whakaava Muller. Anyway, it intrigued me, this statistic. The 43.4 sounded enormously high for just one group. So I thought I'd get off my backside and actually do a little bit of number crunching myself, even though epidemiology isn't my field. I thought I'd make the effort. I've got a few disclaimers here. First of all, I can't stand behind the data that I was sent. I was used what I was given. A number of people shared a few spreadsheets that has some data on. I wasn't entirely lazy. I did try to actually chase up on the numbers, but I could see that it was going to take a large amount of effort, so I just used what I was given. And my presentation isn't really about the numbers themselves and who is doing better or worse. That requires some very serious research. I'm interested in the ways in which populations can be compared, and this is a smorgasbord of examples. The standard technical ways are relative risk and relative odds, incidence and prevalence per 100,000, infection or case fatality rates, IFRs or CFRs, etc. And more sophisticated comparisons are possible using standardization and regression analysis to account for demographics and socioeconomic status. And Peter has touched on those particular techniques. There are lots of data and model complications, such as non-constancy of model parameters over time, low case numbers, definition of the cause of death, the with versus of debate, etc. Anyway, how were these figures calculated? I put the figures in a spreadsheet, so I had population, cases and deaths by ethnicity groupings, and then you could calculate the deaths per 100,000 K of population, and so that's the second to last column. And you can see the Pacifica stand out quite markedly at 33 roughly per 100K of population deaths. The 44% or 43 or 44% odd that was calculated is really the fraction that 33 is of the sum of the deaths per 100,000 K of population in that second to last column. And I thought about that, and I thought, oh, okay, so what's going on here is that you're pretending that there are 100,000 of each of these ethnic groups in a population of 400,000, and you're looking at how many deaths there would be in each of the populations. So yeah, that's got an intuitive meaning. I could go with that. I think it's a good way of comparing the impact on the different populations by taking into account the relative population sizes. So I was quite happy with that. The numbers that are in the spreadsheet are not those used in the CocoNet article. So they must be a bit later because the number of deaths is slightly higher. But you know, the percentages that I get are pretty good. And and then I sort of I'm happier using probabilities. So I calculated sort of probability of a randomly selected person dying. And again, that's fairly easily calculated. Just take the number of deaths divided by the total number of in the population. You get a very small number. And then you can sort of treat the Europeans perhaps as being a base case. And so you divide through the numbers in the second to last column by the European number, the 0.000198. And you get what I call the random person risk of dying from COVID relative to European. And you can see the Pacifica stands out a lot higher. Maori are not quite so high, but surprising. But and then Asian are very low. So, I mean, these calculations are based upon unstandardized populations. So there's a lot more that could be done to the numbers before you actually start calculating these probabilities as well. And then there's another way of sort of comparing, you know, the risk of death. Just look at the number of deaths as a fraction of the number of cases. So instead of deaths being relative to the population, take deaths relative to the number of cases. And so in the last column there, I've got, well, in the second last column, I've just got deaths divided by cases rates, and then I've just divided through by the European fraction 0.0011, and so you get these numbers here. So deaths per case relative to European, Maori 0.676, Pacifica 0.8493, Asian 0.2506, and you think, oh, hold on, these it looks as though these other ethnicities are actually doing better. You know, once they've got COVID, they seem to be dying at a lower rate, lower risk of dying. So I've now got sort of conflicting messages. Anyway, so the next step was to well, let's try and get a better insight into what's going on. And so in this particular spreadsheet, if you look at the second to last column, overall risk of catching then dying from COVID, I've got the same numbers. They're just the deaths per population, those numbers, and then the risk relative to European. It's the same number as I showed on the previous sheet. So it's the product. It's the product of the cases per population and the deaths per cases. So I've the overall number in the right-hand column, the overall risk of dying. Well, sorry, the second to last column, that overall risk of dying is just the product of the cases per population column and the deaths per cases column. And in fact, if you look at the headings, you can see cases divided by population multiplied by deaths per cases just gives you cases, just gives you deaths over population. So there's no need to sort of call on Bayes' rule. You're really just multiplying by 1, where 1 is just cases divided by cases. Well, I hope I'm not baffling you, but what I take from that is that if you look at the cases per population, I've got Pacifica in green there, 0.3477. And so what appears to be happening is that the Pacifica high deaths numbers per 100,000 K of population at the time of this data is heavily influenced by their infection rate. So it's not at all a surprising interpretation. The reason that Pacifica are dying at a higher rate per 100,000 K of population is at least partly due to the fact they're getting infected more easily. And I think there was a lot of debate about the susceptibility of different populations to infection early on in the course of COVID. So that's probably not a surprising result. So if you want to cut down on the number of deaths in any population, then preventing people from getting infected in the first place is a really good place to start. But once they've been infected and they've gone into hospital, it looks as though, you know, the treatment within the hospital system seems to be fairly equitable. Summary of calculations. The CocoNet article per 100,000 K statistics imagines comparing populations of equal size. So it's got validity in that sense, but uses unstandardized raw numbers. If we use the same arithmetic, but using the probability of dying after contracting COVID, we get 31% for Pacifica. We get 31% rather than 44% for Pacifica. But that sort of calculation is completely unjustifiable from a probabilistic point of view. But we get much more insight if we break the total probability of dying into two multiplicative quantities, the probability of getting infected and the probability of dying once infected. I'll hurry through the rest of the slides. What can the Health Quality and Safety Commission take on board? Well, one, explore early warning monitoring systems for emergent health system challenges. Investigate measures of health system emergency preparedness. So at the moment, you know, in the press, we're having this debate about are there crises or aren't there crises? It'd be nice if HQSC could actually have, you know, present a sort of a dashboard that relates to that question. We can also work at developing finer granularity, richer range of data collection and reporting, especially, you know, finer granularity for for Maori statistics. Now, I looked at a couple of other papers. We got the papers by New Zealand groups. This one here, which has got Michael Plank and Andrew Spall and Sean Hendy in it, estimated inequities in COVID-19 infection fatality rates. In this paper, they say that they actually got some IFR data, which was internationally obtained, and they projected it onto New Zealand's population. And then they calculated these IFR estimates starting from two different baselines. One was age-specific, the other was overall population. And this had a large effect on the estimated IFRs, with the age-specific estimates showing lower overall disparity between the ethnic groups. Looking at the average of the two models, it appears to me, anyway, that Pacifica might have an IFR of about 30% higher than for European other. The other paper I looked at was pretty much the same people. You had Hendy, Plank, and Andrew Spall. Maori Pacific people in New Zealand have a higher risk of hospitalisation for COVID-19. That was pretty well a traditional sort of regression type paper where they used logistic regression models around risk of hospitalisation, length of hospital stay, and fatality risk. And they found that they tested some interactions but didn't find anything significant. Age and comorbidity main effects are most influential for risk of hospitalisation, followed by ethnicity, with Pacifica odds being 3.06 times higher than New Zealand European other. Age and ethnicity were the significant main effects for length of hospital stay, with Pacifica staying 5.2 days longer than European other. What did I learn? Well, I learned a lot about the different ways of calculating or comparing populations, the decomposition into overall probability into two stages of infection and then death post-infection was very informative. And then other measures, as I mentioned from those papers, length of stay in hospital, risk of admission into hospital, and there's probably no end to invention in the area of measure definition. Right at the end there, I say that epidemiology must be one of the most exciting areas in which to apply a vast array of established and novel statistical techniques. So it'd be wonderful to be a PhD student working in that sort of an area. Now, thanks to Carl Schuker, who sent me a link to the CocoNet article, Fritz Evil, Principal Advisor Tagata o Le Te Moana, Jonathan Malifa, and Atalaiti Mapa, also the Commission, Richard Hamblin and Catherine Gerard from HQSC. They all listened, read, critiqued, and made suggestions. So thank you very much. We'll stop sharing.
Thank you very much, Vic. Have we got any questions for Vic? Otherwise, I'll ask one. I don't think we have any questions in the chat. We've got a couple of minutes. So Vic, I guess I'm an epidemiologist, so thank you for your talk. And of course, for an epidemiologist, it raises lots of questions as well, some of which you put in your end, in your final comments. And I guess the three things that stick out for me are, we need to know about the quality of the data. And I think we've been worried about whether we capture all, for example, all of the cases in some ethnic groups. We might have differential case diagnosis, and so our estimates might be wrong on that count. So I think it's as you say, it's really important to know where the data comes from before we make too many conclusions from it. I guess I was, as you pointed out, Peter talked about age standardisation, and clearly that the big age difference in the populations between Pacific and the other groups you looked at were a big factor in what you had looked at. So I guess I wanted to ask whether you looked at trying to age standardise your estimates, because I think when you do that, you'll see that the death rates are higher than you would expect for Pacific. Did you have a think about that?
No, I had to think about it, but my paid job at HQSC isn't really in the data analysis line, so I just crunched some numbers and learnt a bit from it, and and here I am.
No, thank you for that. And I think it's good for it's great for even people who are not data people to get in there and think about what the implications of the different ways of dealing with the data are. So I really appreciate that. Thank you, Vic.
Yeah.
So I think we're on time for our next presenter. So I think we've got Emily from HQSC as well.
Yes, me and also Catherine Gerard from HQSC. Thanks, Ruth.
And talking about libraries and atlases. Great. Okay, I'll hand it over to you, Emily.
Kia ora koutou. Shall I kick off, Emily, and then?
Yes, great.
Brilliant.
Can I just check? Can you see the full screen slides now?
Yep.
As well, thanks.
Kia ora. So, ko Catherine Gerard tōku wingawa. Thank you. I'm very happy to be co-presenting today with my colleague Emily Mountier. So I'm Assistant Director in Health Quality Intelligence at the Commission. And I think when this call for abstracts came through, one of the kind of areas of interest or topics of interest was public health intelligence in the new system. And I thought, what an interesting thing to think about. And what do we have? And actually, what does it look like in the changing reform agenda? So we can go to the next slide. One of the goals of the health system, and one that Andrew Little has articulated quite a lot, is that we want to ensure that every New Zealander gets access to the healthcare they need, irrespective of who they are and where they live, which is very interesting. And if we go to the next slide, I think it creates quite a lot of challenges for the healthcare system. The first thing that you need to know is what quality healthcare is. You know, can we measure it? How do we know that people are getting the care they need? What can we use in our public health intelligence data sets to assess that? And if they aren't getting the care that they need, what can we do to change this? Because obviously this isn't a new problem. And you know, there's been a lot of talk about postcode lottery, but you know, what does it actually mean, and how do you genuinely and authentically address it? So if we go to the next slide, we've got quality improvement frameworks where there's international ones. So the Institute of Medicine has the 6 domains of quality. New Zealand adapted a number of years ago the IHI's triple aim for quality improvement that we use as a guiding kind of framework for when you're looking at measuring quality. What are the things that you need to include in your framework? What do you need to consider? So the triple aim for quality improvement includes improving quality, safety and experience of care for people and their whānau, improving the health and equity of all populations, and then on the bottom part of the triangle, that you have best value. So that can be a really useful kind of guiding framework for us when we're looking at measuring the quality of care. But then the next question is really, you know, how do we know what care people are getting? And that's actually where I think the atlases do go a long way. So Emily, if we can go to the next slide. So New Zealand established its Atlas of Healthcare Variation in 2012. And if we kind of cast our minds back to then, at that time, there was a lot of data fed into the centre in terms of, you know, inpatient admissions, pharmaceutical dispensings, attendances at primary care, laboratory dispensings, but not a lot of data was actually published. And when we first started publishing Atlas data, there was a lot of concern and pushback from all around. And in fact, there are 1 or 2 atlases that were never made public because of discomfort from the centre. So I think it's interesting to kind of remember that now when we're in an era where actually there's a lot more availability and transparency around the data that we have. In terms of the Atlas, well, it just shows variation between DHBs. We typically do it within domains. So we'll look within a particular topic area, like people with gout or people with cardiovascular disease. And we'll base a series of indicators that are based off clinical guidelines. So we'll look at what best practices, we'll try and create indicators that get as close to it as we can. And usually what we can measure at the national level is a little bit limited. And then we put a bit of context around it. And I think that's always really important, is that we interpret what we think the measures mean, what the limitations are, and then what questions you might ask. So it's very much designed to say, this is what we're seeing in the way of variation. Does this look about right? Where are people getting this variation? But we can't really put an ideal level on it, because to get an ideal level, you most often need clinical detail, clinical diagnostic codes that we don't have at the national level. However, what we have seen, and what has happened over the years of the atlases, is we've seen a lot of variation. So if we go to the next slide, I thought I'd just give you a sample of some of our, you know, greatest hits. So this one here looks at the dispensing of a strong opioid, and you can see that Capital and Coast has a rate of 10.6 per 1,000 population, compared with Wairarapa, which had 25.7 per 1,000 population. And that was a really interesting piece of analysis to do, because when it comes down to it, we don't think that people in Wairarapa have 2.5 times the need for opioids that people in Capital and Coast do. And actually there are a lot of reasons and a lot of drivers for the variation in this one that relate partly to the system, but also relate to regional quality improvement efforts. So for instance, Capital and Coast had done a lot of activity to reduce their strong opioid dispensing, whilst Wairarapa had some rather interesting things going on around their first specialist appointment rates, where if you wanted to have a first specialist appointment for surgery, for an elective surgery, for instance, for hip or knee replacement, you needed to be on a strong opioid. So that was a fairly strong driver for increasing their rates. Interesting. The next one that we have is looking at variation by ethnicity. So we have seen this again and again and again, that there are strong differences by ethnic group within New Zealand. So this is looking at people regularly receiving urate lowering therapy of a cohort who have identified as having gout. And what you can see is that the data don't change much over time. So Māori and Pacific are consistently less likely to regularly receive treatment for their gout. There's been a number of papers that we've published in the NZMJ highlighting this issue. And I think actually, you know, there has been improvement made, but certainly not to the point where the gap's closing that much. Another example of variation that we've seen, if we can go to the next slide, Emily, is looking at variation by gender. So this is looking at people who were admitted for ischemic heart disease. The guidelines best practice is that following admission, secondary prevention should include triple therapy. And without going into too much detail, I think the colours kind of give it away. So if you are red, you are less than 55% of those who are hospitalised for a cardiovascular condition regularly received triple therapy in the year after. Women much less likely to do so than men. Again, no obvious kind of reason why that might be, other than, goodness me, that does suggest that there is some perhaps unwarranted variation going on. So if we go to the next slide, a lot of the work on unwarranted variation really was pioneered by a guy called Professor John Wenberg. He started his work back in the kind of 1990s. And he's defined unwarranted variation as being variation in the utilisation of healthcare services that can't be explained by variation in patient illness or patient preference. And I think what this tells you is that we've seen some variation. We don't know how much of it's unwarranted versus how much is warranted, but it certainly raises some interesting questions. And usually the actions that we need to take to address this variation occur at multiple levels within the system. So if we go to the next slide, and this is really just a kind of breaking it down into the national actions, the regional actions, and the practice and local level actions. So often further analysis is required, but in terms of getting towards the stated goal of making sure that everybody gets the healthcare that they need in New Zealand, this can be a way to systematically look at it. And if we click on it, I think we'll come to the measures library, which Emily's going to talk about, and we see this as being part of a tool at the national level that can help to reduce or get towards providing people with quality care. So I'll hand over to Emily. Thank you. Kia ora.
Kia ora, Catherine, and kia ora koutou. So yes, the measures library in its current iteration is a new piece of work for the Commission with input and user testing and all kinds of expertise from others in the health sector. Its first iteration was published at the end of last month, and it is a web app designed for curating and maintaining shared measures, definitions and data across the sector, which, as Catherine has said, is really important and is a fundamental building block for quality improvement. And in the health sector, we have so many robust and well-designed measures available of health system quality, but if you want to browse what's there or be able to group together measures across more than one area or topic, you might end up needing to click into many different dashboards. So the measures library is about moving towards having a single place where you could go to see a summary of what's available, get some information and download some data, and also have links accessible to go to the source data visualization if the measures are published elsewhere. So this is really important. As with the changes to the health system, there will be changes to the ways we measure system performance and quality, and we want to make it really easy to understand and use data, as well as enabling, as you see, line of sight from day-to-day clinical care through to health system measures. And this is really important for informing and supporting improvement. What is actually in the measures library? It works as a repository of information for measures of health system quality across the board. So from acute care, continuing care and rehab, and in the future, we'll be adding measures around finance and health human resources as well as those are developed. And the idea is that this can then be used to accelerate improvement in healthcare across Aotearoa. And it's aimed mainly at healthcare sector users, so including but not limited to business analysts, health service researchers and clinical leaders. You can specifically access a bunch of different things in the measures library. There will be high-level data and data visualizations, technical definitions. You can download methodology documents for each measure, but also things like case studies, quality improvement considerations, and relevant resources to support the management and use of the measure to drive quality improvement. This is just its first iteration, and there's a plan for continued development over the next 12 months and beyond. But one of the things that we really want this resource to do is provide clear links to contributory measures for any given measure that appears in the library to show how process or structural measures can influence outcomes. And yeah, like many good ideas, it's not a new idea to do this. It's a model that's in use overseas and also, as people will remember, has been tried before in Aotearoa. But yes, we're repeating it because it's a good idea and it's something that we need, particularly in the current context. Right, I see that's our 5-minute call. My remaining slides are just examples of what the measures library looks like. You can also see this for yourself by going to the link that I've linked in this slide. In my starting slide. And you can see we've got some things on the agenda for the next steps. But yes, back to you, Catherine, if you had anything more to add at this time.
Nothing, thank you, Emily, and apologies, I talked too much and didn't leave you enough time to do your slides.
No, not at all.
Thank you very much, Emily and Catherine. Really exciting to see as a health service researcher. It's really exciting to see this library of measures coming together, and would be really interested to watch that develop. Does anyone have any questions for Emily or Catherine? My fellow co-hosts, help me. Are there any hands up? Nope. I think everyone's tired by the end of our third afternoon. So no, thank you very much. I guess the question that I had was probably for you, Catherine. You talked about some of the greatest hits of the health quality and safety atlases. What's your greatest success story, or your greatest sense in which the producing of this information you feel has really been important in making a change to practice?
Great question. Yeah, look, there's been, gosh, all of them feel a little bit like a child. You kind of nurse them through. I think polypharmacy I really like because before we had that atlas, there was no definition and common understanding in New Zealand about what polypharmacy was. And I think defining it has really created the opportunity for people to then look at it and make changes. I think the ones that have used the health service, health tracker populations like gout and diabetes have been really good, because they've used that existing data and have genuinely, I think, helped with improvement activity there. And one of the other ones was the surgical atlas, which looked at grommet insertion rates. Now, that was one of our second ones, I think, that we ever published, hugely controversial. There was a lot of arguments with ENT surgeons about it at the time that it was published, a lot of concern that it was going to be used as a rationing tool. And actually what we said and what we learnt in New Zealand is that our atlases highlight underuse and overuse. And we recently published an NZMJ with some ENT surgeons, which is really wonderful to kind of become a collaboration and not a tool for judgment. And we recently published comparing grommet insertion rates between ADHB and Counties Manukau, and it's really fascinating. Just you have the same providers often working across those two DHBs, same specialists, and yet really different intervention rates between Māori and Pacific. That really tell you something about the system, and actually highlight the benefit of what we hope will come out of the health system reforms. So yes, lots.
Thank you, Catherine. That's great. Oh, Barry.
Yeah, Catherine, thank you and Emily for that presentation. It brings to mind something, probably by looking at you well before your time in this health system, but way back, I was involved with doing something similar when I was part of the Ministry of Health, Department of Health, publishing stuff that the actual department, the DHBs had collected. The idea was just to publish it, this is what you've sent us, and actually receive the same reaction from them as obviously you did, is that you had no right to publish this. And we said, well, you gave it to us, we're just producing it. And it was actually interesting, their reaction after a period of time. Some of them, data quality wasn't very good and they objected, but in fact they collected it. So well done on doing it. My view is if people collect data and send it in, then you have an obligation to do something with it. So good work.
Thank you. I mean, one of the things from what we see internationally is everybody gets the same response. The data are wrong, and they don't apply to me. My patients are different. And then eventually people acknowledge that, in fact, what the variation is showing might be genuine and might be something that's worth paying attention to. I think in terms of the data are wrong, we have so moved on from that conversation, and it's lovely when we publish them now. We get engagement on terms of what the data is showing rather than the pushback on there's a problem with the data. So we have seen a lot of progress over the 10 years or so.
Great, thank you very much, Catherine and Emily. Great to have you part of today. So now moving on to our next speaker. We've got a slight change in person from who was originally on the program, but we have Jeremy Severinsen joining us from Ōbaka, talking about modern geospatial and its use in the health sector. So I'll hand over to you, Jeremy.
Kia ora koutou. Thank you, Ruth. I'll just share my screen very quickly, and hopefully it works. There we go. Can everybody see it? Excellent. Now, contrary to the name at the bottom of my picture, I am very close to my wife, but I'm not Sarah. I am Jeremy Severinsen, and I'm a business analyst and a project manager at Ōbaka. So we're a specialist geospatial data analysis company based in Christchurch, and my background's not actually in the health sector. So I spent several years in government and also in the private sector, but all of it in the environmental space. And so what I'm going to talk through in this presentation is is not specifically work that we've done in the health sector, but rather work that we've done in other sectors that that sort of identify some learnings and principles and sort of cross-sector collaboration that could really amplify outcomes. So I'm going to first of all take a step back in time and back up to first principles. Some of you will have seen this stuff before, I would say, and then I'm going to move into some of the work we've done in other areas and some of the insights that we've achieved there. So just want to talk about this very quickly rather than read through it, but globally, various nations around the world are increasingly turning to location information as the thing that holds things together and the thing that will help us solve you know, emerging and future challenges. And I want to hone in very quickly on this part of the UK's geospatial strategy, which talks about how location data will be the unifying thing that holds us together. And I think in a New Zealand context, we're particularly engaged in this because our history is a very close connection between people and the environment, whether it's the built environment or the natural environment. Te Ao Māori, which is one of our unique parameters of our nation, really speaks to that connection between people and the environment. So in this way, you know, we have the potential to lead in this space, and other countries are looking in that same direction. Now, anyone that did geography at university will have come across Waldo Tobler's first law of geography. Everything is related to everything else, but near things are more related than distant things. It seems like a unquestionable universal truth. And it's definitely true in terms of people and the environment that they live in. So traditionally, organizationally, we conceptualize work in terms of functional silos, functional areas. But in actual fact, all of those things play out at place in one way, shape or form, and there are interactions that are non-functional, but rather place-based, that will really give us greater insights. And of course, the health sector was actually where modern geospatial began, with John Snow. Perhaps not this John Snow, but we will go back in time a little bit to this John Snow. And I don't know how many people are familiar with the cholera map from the UK from a couple of centuries ago, but it was very much that giving effect to that principle of everything is related to everything else in some way, shape or form. Clustering, spatial insights, you name it. It started back in the 1800s and we're still doing it now. And it started in the health sector. And so that has grown now out into the environmental sector, out to other social service sectors, but we can bring all that back together to give greater insights in health. Now, how do we move from silos to a system? And you know, we're very clear at Orbica that data is the foundation for that. It is often domain specific. It is often held in domain specific ways. And there's a big, our favorite word on this slide at Orbica is democratizing. So it's that interoperability, that interconnectivity, access, equity of access to data across multiple systems and multiple sectors to really give that, that high level insight. And it's not just the data, so it's the analytics as well. You know, we have worked with other social sector providers, we've worked with environmental companies and agencies, and there's some methodologies that get built in those other sectors that are actually really, really relevant and can inform what we do in the health space. So the question is, what is the pathway then to do that from data silos, analytic silos, through to system level thinking? So we at Orbica talk about two things. We talk about geo-AI and geo-BI, and that's business intelligence. Now, geo-AI, we know we've all heard about artificial intelligence before. Geo AI has the potential to take health sector specific data and combine it with other big data sets. Some of them would be remotely sensed, or they could come from anywhere. But the point is it can take it to scale very quickly and very easily. So you move from the John Snow cholera map, very localized, to how do we gain these national and even international level insights using machine intelligence, and that not only helps with scale, but it helps with pace. And so there's some technology advancements that have happened that will really help us chart our future pathway. The next thing, of course, is what we've called here the storytelling engine. Now, we sometimes call that Geo BI or Geo Business Intelligence, but it's really what that is storytelling. So data, some people speak the data language. I sort of do. A lot of people speak it better than me, but to really amplify that impact, someone's got to turn it into human language, and being able to tell the story about those insights and those results is a critical part of the data intelligence engine. Because it goes in a cycle. Data turns into information, to knowledge, they inform our actions, they deliver outcomes, and then based on that, we can make a judgment about what worked and what didn't, and start all over. Did we collect the right data in the first place? Did we not? We can refine that. That's the beauty of a data information knowledge cycle, because it is iterative and it is agile, and it does learn as we learn more. And every time you go around that cycle, you can extract more value from that data. So the data ecosystem is important. It lives in a conceptual, theoretical world, but it also needs to live in a real practical world that does real wonderful things for real people. And how to translate those theoretical learnings and aspirations into real life interventions is where next generation technologies come into play. Now, here, I would have loved to have given you an interactive map demo because I love playing with maps. But here is a screenshot of a tool and a map that we've been working with another social service sector to produce. And what it shows is Christchurch, and what it shows is supply and demand. So this is moving from our problem solving in the moment, or analysing, reviewing, learning from the past, into projecting the future and targeting interventions based on projected intelligence. Now, this map is built from a number of publicly available data sets that are generally kept in silos and only accessed when in a particular tool like this. What we're seeing here is population projection by the SA2 polygon, so a certain sort of census level. And so those are the purple polygons where the population is projected to either increase or decrease, and then the dots are sites of provision of a particular service. In this case, it's in the education space. Now, what this is showing us is potential sufficiency of supply or potential insufficiency of supply to meet demand. And there's a number of other analytical components that sit behind this. What it shows is that in order to appropriately target a service to a certain sector, we need to know where that sector is growing, or a demographic, potentially, where it's growing and where it's not. So imagine, just off the top of my head, pharmacy provision. Some of the contextual data that you might want to know and project forward about where to target pharmacy provision includes population growth or negative growth, as the case may be, but also age demographics, ethnicity demographics, and so on and so on. You know, sites of interest, rest homes, hospitals, for example, all of those things that inform a place-based relationship between service and a demand. And we're very fortunate with the census data in New Zealand that it can project forward 10 years at this point. So we can construct an analytical pipeline where we can year on year predict out to 2032 what demand might look like for a particular service group in a particular place. Now, the great thing about these next generation technologies, and in this case we're using an open source stack, so it's accessible, it doesn't come with the licensing fees that proprietary geospatial solutions do, and so it democratizes access to data intelligence and not just data itself. You know, at a government level in New Zealand, we've focused a lot on supply of raw data so that the private sector can add value. What we're looking at here is democratizing access to insights from that data, which is the next level in that supply chain that's really, really important in terms of real outcomes. So we're seeing another subset of Christchurch here, but we're seeing the data displayed in multiple ways because people have multiple uses for that. You'll see some blank spaces where I've censored out or redacted some of the more case-specific information that I couldn't share today. But at a tooling and principle level, these dashboard charts and graphs are being driven by the analytics under the map. So as you pan the map or zoom or select a specific subset, these statistics and insights will refresh in real time. So what we're essentially seeing is, looking at the map, the charts are saying there are 303 entities that provide a particular service in that area, and the population is projected to slightly increase and then dramatically decrease. So that tells us, you know, perhaps we have a potential excess of supply in the future that could be redirected somewhere else. Oh, that's the 5-minute call. I'll carry on. And also driving some of those ethnicity stats out of there. And I know that the previous speaker discussed, you know, equity of access for Māori and Pacifica and, you know, uptake of services. And so predicting where that distribution might be is something that these next generation tools can really open up to a whole range of users, whether they're regulatory agencies, private business, or even just the general public. I will rapidly move on from this slide because it's just another depiction of the charts and dashboards that we can see driven by spatial data. And I know that time is closing in on me. But the last thing I want to cover is the environmental sector and how some of the methods there can inform what we do. So this is, again, Christchurch City. This is an example of where GeoAI has been used with large-scale data sets to detect vegetation, and in particular trees and tree corridors within the city. And why that's important is because so as a country, we fund the collection of these very large data sets. We fund LiDAR collection. You may have seen it in the news recently. Big LiDAR data sets collected over multiple parts of the country. The traditional business use case for that is in the environmental sector, and whether that's natural environment or built environment. But equally, those benefits could be drawn out another step into the human and social sector. You know, where can we access green prescriptions? Coming back to our previous ethnicity and population growth predictions, are our green spaces sufficient for what we project our demand to be over the next 10 years, year on year? And so there are some real exciting methodologies that are being developed in other sectors that if we can democratize access both to the data and the analytics behind the data, will really drive some beneficial outcomes in sectors that people probably didn't think of when they were originally collecting those data sets. Because everything is related to everything else, especially when they're in the same place. And that, I think I've come in on time.
Very timely. Thank you. Thank you, Jeremy. Thank you for a really great talk, and great to have all the pictures and the amazing maps that you were showing us. And also I totally agree that it's great to have the data, but it's about telling the stories with the data and democratizing the access to the stories as well as the raw data. So great to see that. Do we have any questions from anybody? Otherwise I will ask one. No, I can't see any hands up or any questions in the chat. So I guess, Jeremy, I was wondering if you had any thoughts about what the barriers are of, I'll ask my question quickly, Peter, and then you can go, about what the barriers are to using some of these technologies in the health space.
Yeah, that's a very good question. I think I think some of the barriers are social. So I will go on and on about social process within projects, and you know, bringing people on a journey. It comes back to that storytelling. So so it's about connectivity with people who are driving the different sectors and systems at all levels. You know, a trusted governance level, a trusted implementation level. And then the tooling to actually make that available. So you need the governance level conversations to create the drive to make some of these analytics available, and then the platform and the tooling to have interfaces with people where they can readily access it and engage with it regardless of their skill levels. You know, I think globally we have 200,000 specialist geospatial consultants or specialists. There are 1 million data scientists, and but these insights are spatial. So how do we get that knowledge from the spatial sector and make it accessible through a thing that is intuitive, or an interface that's intuitive for people for whatever they want to do?
Thank you, Jeremy. Peter. Oh, you're on mute, Peter.
Thank you, Jeremy. That was really good. I'm very interested in the projections that you've made, and from what I could gather, most of the projections were based on population increases. Have you built any other factors into the model, like changes in climate, changes in income, changes in rates of disease that aren't related to population increases?
So we have built some other factors into those models, not necessarily rates of disease, but around projecting population, there are things like district and urban planning zonings, and you know, future planning frameworks around that. So there's those things, and then there's the other network information. So you have a roading network. We understand in some way, and sometimes we understand in real time, crowdsourcing data, how people flow through a transportation network, for example, whether it's a roading or a walking or other ways that they move around an urban environment. And so being able to track and analyze those volumes of people movement, particularly in an urban space, that is another thing that's helping to inform these models. They're iterative models, and they're based at the SA2 census block level. And so how people travel to and from SA2 polygons or census blocks to where they work, where they live, where they have an activity that may not be work or live, that's really important to help inform that as well.
Thank you.
Thank you. Barry, I think have we got our next speaker online? Patrick, you can tell us. Barry, you can ask a question while we check.
So our next speaker is pre-recorded. We are running into their time slot now, so Barry, you might need to save it for another occasion.
Just make a quick comment. Well done, Jeremy. Well done, Jeremy. And I know that Kurt's there in the ether somewhere, but I think that you've raised a really good point, and it follows on with what Ruth just said, is that we've seen in this conference an awful lot of excellent work that's totally unconnected. And I think that, you know, once you start putting walls around people, they start with working, you know, health does their thing, somebody else does their thing. And I think it's what you've demonstrated here again, and Ruth's question is that it's actually the workers that have got to work together, not the organisations. So well done.
Thank you, Barry.
Kia ora koutou. My name's Kylie Mason, and I work in the EHINZ team, and today I'm really excited to be able to present to you on our social vulnerability indicators. Now these indicators came from a research project that we were funded through the Natural Hazards Research Platform a couple of years ago to develop a set of social vulnerability indicators for flooding in New Zealand, and we used a case study of Porirua to test out the indicators. So a couple of quick points before I start. These indicators are a useful way for measuring this broad concept of social vulnerability, and at the really local level, which is very useful information for people on the ground. We've also got a range of useful data visualization tools if you're interested in exploring the indicators yourself and using them for your own work. And also I think this is a really useful example of how we can turn data into information and indeed intelligence for informing actions within the health sector, but also within other sectors like the civil defence and emergency management sector. So just to give you an overview of what I'll be talking about today, here's my outline. So I'll just be explaining a little bit about social vulnerability to natural hazards. I'll go briefly through the methods for developing the indicators. I'll show you the indicator list that we've got, and a couple of data visualization tools that you can use for exploring the indicators, and then potential uses. So just to set the scene, we all know that New Zealand has many natural hazards. So in the last 10 to 15 years, we've experienced serious earthquakes, floods, wildfires, and coastal flooding from large storm events, not to mention COVID-19 pandemic. And of course, some of these things, particularly floods and wildfires, droughts and coastal flooding, are likely to become more frequent and potentially more severe with the impacts of climate change in the future. Now, in much the same way as social determinants of health can influence people's health status, not everyone is affected equally in disasters. So this quote comes from an American researcher. I'm not sure how relevant it is in the New Zealand context, but I think it provides a really useful context and rationale for why we're thinking about social vulnerability. Existing emergency plans are designed for people who can walk, run, drive, see, hear, pay, and quickly respond to directions. These assumptions do not align with the reality that at least half of the American population can be considered vulnerable to disasters because of their existing social circumstances. So this idea leads us into this concept of social vulnerability. There's no one definition that's widely recognised about social vulnerability, but this is a commonly used one that refer to the characteristics that influence people's capacity to anticipate, cope with, and recover from the impacts of hazards. And there's three main things that social vulnerability relates to. So it's about people's exposure, their susceptibility, and also a lack of resilience, however you might want to define resilience. So like I mentioned, we have developed a set of social vulnerability indicators for New Zealand for two time points, 2013 and 2018. Here's a brief summary of our methods. So we've got a three-stage process that we go through when we develop all of our environmental health indicators. So we use the same process, and this based on best practice. So we've got a scoping stage, a selection stage, and then a design stage. And I think the most important thing that I wanted to draw your attention to was this first point in the selection stage of creating a conceptual framework. We want to have some kind of framework that summarizes how we're thinking about whatever the issue is, in this case social vulnerability, to guide the indicator selection. And in this way we have a concept-driven approach rather than a data-driven approach. I'll just add that during our research project, we incorporated end user input throughout the process, and we did this with our stakeholder group, which included representatives from our local public health unit, PHO, DHB emergency planners, local council, local CDM group, Civil Defence and Emergency Management group, and GNS Science and NIWA. I think that's everyone. I missed someone. We also included Mātauranga Māori through one of our project team members, and also through working with Ngāti Toa Iwi out in Porirua. The end product is we had some indicators that could be used by our end users. So when we were creating a conceptual framework, ideally you just go get one that's already available. There wasn't for social vulnerability, but there were some that picked up on different aspects. So here's the main one we used, the MOVE framework. It's quite widely used across the world, stands for Methods for the Improvement of Vulnerability Assessments in Europe. And I'll just briefly talk it through. The main bit is the green box. So you've got hazards up the top, which refers to sort of natural hazards or maybe pandemics, for example. It interacts with society in the orange box to give you some kind of risk down the bottom. And in the orange box, you've got three aspects of vulnerability. You've got exposure in time and space, you've got susceptibility, and you've got a lack of resilience. And this talks about the capacity to anticipate, cope, and recover. Now, we use this framework to help select our indicators, but we needed some way of understanding what lack of resilience looks like. And for that, we drew on another model that existed called the Circle of Capacities. And it's basically a circle with 6 wedges, and each wedge is a type of capacity that helps people respond in a disaster. And so we mushed them together. And so now we have this framework. Exposure, susceptibility, which is basically age and health status, health and disability, and then resilience. And so this is the circle of capacities. So it's about having enough money to cope with crises and losses, social connectedness, knowledge, awareness, and skills to face hazards. So do you understand the information? Can you act on it? Are you aware of the hazards? Having decent housing, having enough food and water to cope with shortage, and also decision making and participation in that. So a lack of resilience can increase vulnerability, and vulnerability can lead to negative impacts on people's health and well-being. So for 2018, here's our indicator list. There's quite a few, depending on what kind of information you're after. So we've got indicators about exposure and also occupational exposure for people who are more likely to be exposed during a disaster. We've got children, older people, health and disability, and also some indicators about lack of resilience. And there's some interesting things in there that I think are relevant when we're even thinking just about barriers to healthcare access. So people who do not speak English or who don't have access to the internet, or single parent households, for example. We can also use the conceptual framework to think about geographic locations. So here we've got, say, schools and ECEs, where children might cluster, rest homes and retirement villages where older adults might be, and same goes for these health facilities and emergency services facilities, temporary housing or visitor accommodation, where people might not be so aware, or might be more transient people, not aware of the hazards and not have connections with people in the local neighbourhood. And so we can think about these kinds of geographic locations when we're overlaying hazard zones. So thinking about if you're putting in a school or an ECE, not putting them into a flood zone where there's really deep, fast-moving waters, for example. So we've got a couple of tools for exploring these indicators at the SA2 level, which is local neighbourhood level. So this is our online story map. And And so you can access it via the website through our EHINZ website. You'll see that there's different tabs along the top that represent the different dimensions of social vulnerability in the conceptual framework. So if we went to, say, awareness, and it can take a little bit of time to load up, but hopefully it won't take that long. It's got all the data by SA2 for the whole of the country. And so each tab has the indicators that are relevant to that domain. So here we've got households with no access to the internet. We can zoom in with our mouse or by clicking on the region. And here's, say, the Wellington region. Can zoom in a bit more. And so we can see the SA2s, the neighbourhoods that have higher levels of households with no access to the internet. So, for example, up in Taita in Lower Hutt, got 24% of households with no access to the internet, and Cannons Creek about 26%. And even so, these data relate to 2018, and they may have changed since then, but I think it's likely that the patterns are still likely to be the same of where there's lower access to the internet. Another indicator here is people with limited English proficiency, so who don't speak English, and so we can see, say, quite low percentage in Porirua Central who don't speak English. In Taita, 3.4%. We can look down in Wellington, for example. Here we've got Kilburnie East, we've got 5.8% of people don't speak English. So you've got all the different indicators are accessible, and for the whole country, you can zoom in and explore the area that you want. So that's that tool, and it's pretty helpful for just a quick view about your local area, about what's going on there. We also have heat maps, and these are basically tables with the data, the percentages, but helpfully you've got it. The colours can give you a cue as to the highs and the lows. So here the dark orange means higher levels for that particular indicator. So in the column, the highest levels are coloured darker shades. This is for Porirua City Council area, because that was our case study area at the SA2 level. And you can see there's some areas that have higher vulnerability levels across multiple dimensions, particularly around Cannons Creek and Waitangiroa. And interestingly, actually, if you look at the flood maps for those areas, there is actually some flood zones in those areas. So that would be good evidence. This provides sort of evidence and support for potential flood mitigation works being useful in those areas. We also have these heat maps available at the higher level. So here's by district, district health board as we used to know them, and when they were produced, they were at that level. So you can get an overview at the higher level in your area, in your district, about the kinds of these kinds of indicators, if that's helpful. So potential uses for these indicators, well, they're useful for flooding because that was what the project was set up for originally. And I've worked through the rationale for the indicators, and I believe they're very likely to be useful for other sudden onset disasters, so like earthquakes, tsunami, heat waves, and wildfires. And I believe they're also relevant for infectious disease pandemics like COVID-19 and influenza. And likely to be useful for thinking about climate change, particularly those sudden onset kind of impacts from climate change. I think where these indicators are particularly useful is it's a quick view for understanding vulnerabilities. So at a glance, so you can see, you can just zoom in on the map, pick an indicator, understand it for your local area. And this might even be helpful for understanding, say, barriers to healthcare. So thinking about households with no internet or no mobile phone or no car, where you're going to have difficulties accessing healthcare, perhaps. Maybe single parent households where there might be childcare issues, damp and mouldy dwellings and crowded households in terms of people, say, isolating from COVID-19 or experiencing impacts on their health from poor housing quality. So like I said, the indicators are all available at the SA2 level, at the TA and district levels, and also Auckland local board areas. The indicators are, of course, useful for the 4 R's, for the SEDM sector and health sector, so civil defence and emergency management. And I'll run through the 4 R's if you're not familiar with them. So basically, the 4 R's are risk reduction, readiness, response, and recovery. So particularly for a response, the indicators are useful for understanding the local population and just having a quick understanding without having to put people on the ground to go around door knocking. You can actually understand some of the challenges that the local community might be facing before going ahead and doing that. And ultimately, it's about making sure that response efforts are equitable based on the greatest need. Similar rationale for recovery, and also for readiness, understand the population and their likely needs, and this can inform emergency management planning. You can also identify these point locations, geographic locations in hazard zones, and just have everything ready to go for when disaster strikes, so to speak. And in terms of risk reduction, like I mentioned with the Porirua flood zones, using the information about vulnerability and vulnerable populations in certain areas to support infrastructure upgrades and hazard mitigation works to reduce the risk of floods in those areas. And as part of that research project, we also thought about how to incorporate this kind of thinking into land use planning, and really that's about ensuring that locations such as early childhood centres and schools don't get built in high hazard zones. So thinking about the people that are going to be using a building, for example, or an activity that's going to be happening in a building, making sure that building is not in a high hazard zone. Very quickly, a case study of Canterbury with acknowledgements to Steve Ferris from ECAN. So about a year ago, the Canterbury region experienced an extreme rainfall event, and there was a lot of flooding and a region-wide state of emergency. So basically, we got contacted by ECAN, Environment Canterbury, and the Regional Emergency Coordination Centre. And so we sent them our shapefiles of the indicators to put into their basically their online mapping system, and they use this information to configure some tools pretty quickly, and so they could basically interrogate the information and use the information to inform their response. And so one example was in a local area, just seeing that there was about 10% of the population who are Asian, sort of perked their interest, and they went digging some more and found that it was, I think it was a Filipino community, but without that information, they may not have picked up on that. So they said their response is often about gathering intelligence from lots of different areas, and this is one source of intelligence that can help shape their response and provide some breadcrumbs of where to look further. So just a few concluding slides. The indicator data is freely available to use on our EHINZ website. So you've got access to the story map, the heat maps, and an indicator data set if you'd like to download that. If you're into ArcGIS stuff and you know what a REST service is, we have a REST service. If you don't know what it is, doesn't matter. Move on. We've got a few next steps that we'd really like to continue for our project. Particularly around developing indicators about health status, mental health status, and disability. They're just a bit more complex than what we've done so far and need a bit more work. And also investigate the relevance for other hazards, particularly climate change, I think would be particularly pertinent. And also thinking about multiple vulnerabilities and overlapping vulnerabilities. So in conclusion, I believe these indicators are a useful tool for understanding who's most vulnerable to the impacts of hazards and where they live in, at a local level. The indicators are relevant for natural hazards and pandemics, I believe, particularly sort of sudden onset things, but you can use the conceptual framework to think through how the different dimensions would be applicable and if they'd be applicable. So the indicator is useful for a number of sectors, including the health sector, SEDM sector, local councils, and also for hazard risk reduction, which can incorporate other other sectors as well. And you can access all this information from our EHINZ website. So here is the information if you want anything else. And if you have any questions, feel free to contact me or someone in the team. And thank you very much.
We now have Justine Lester joining us from .loves Data to talk to us about, about localities data in the new public health system. So really interesting to hear what you have to say for us, Justine. Thank you.
Thank you very much, Ruth, and looking forward to presenting this information to you. What I'll do is I'll just share my screen and I'll check that people can see that we're looking at the same screen as well. Just confirming you can all see the screen there. Anyone able to confirm?
You're good to go.
Yep, we can see it.
Great.
Yep.
Fantastic. Now, as I understand it, we've got about 20 minutes. I'll focus perhaps on the first 10-15 minutes, really just talking about localities planning in the health sector and some data dashboards that we have pulled together for 67 territorial authorities around the country. And then if you've got any questions, just please feel free to ask. This is very much a new space for government and health and public service. And as you'll see here, just from an overview page, I've just sort of set out what localities planning is. So Health NZ and the Māori Health Authority, as they've been established on the 1st of July, are setting up localities across the country, with 9 localities being established in the first phase, and then over time that being extended to the rest of the country. The 9 priority areas at the moment largely are parts of New Zealand distributed across the Motu, where there is a high deprivation need, and therefore, as is often the case for high deprivation communities, health outcomes tend to be far lower than they are for more affluent communities or those that are determined to be less deprived. So localities planning really is, as I've pointed out here in the bullet points, it's a place-based approach to planning and delivering health and wellbeing services. Very much a focus on local, delivering local and making local decisions, but having good quality local data. That has been a problem up until now. We have a very highly centralised system of data collection in New Zealand, with Stats NZ being focused on collecting that on behalf of communities. But that's largely at a regional level because Stats NZ has been focused on a national context and has dived down to that regional level as well. However, there are only 16 regions that they collect data for across the country. While you can get into the IDI and get much more granular than that, that's not accessible for most individuals and certainly not for anyone that doesn't have a specific data science or research background. As you'll be aware, there are many more than 16 councils across the country, more than 16. There are 67 in total, and therefore, and there are about 2,253 communities at the SA2 level, which is a small scale community or about the size of a large suburb. So what we're focused on and what Health NZ and the Māori Health Authority is focused on is getting data for those 2,253 local communities. Now, if you look at that last bullet point there, you'll see that this rollout of localities and localities data is happening over the next 2 years. This will be phased so that different parts of the country will be stood up each quarter, and every New Zealand community will have its own locality and its own local data by July 2024. So this will be for the first time in terms of public health and service and delivery, since New Zealand effectively has delivered public health service. I will take you through now an example of what localities data could look like. This is very much our version of it, but based on our experience in delivering localities data to about 40 different councils across the country. That also extends to a large number of social service organisations, about 10 different PHOs, and a whole host of communities groups as well. So this has been developed over the course of the last 3 years and was launched in February 2022, based off of the feedback of all of these community organisations and public sector networks. You'll see here, while this is a live dashboard that's delivered in Power BI, it's automated so that it updates monthly with all local data. I've collated a whole series of screenshots here just for ease of access and reference through a presentation. If you'll click on the button here, where it says select the district you'd like to explore, you'd be able to access all 67 territorial authorities in New Zealand, and then from each of those territorial authorities you could go down to their local community areas, and again they total up to 2,253 across the country. It's just an example. We can go from Hamilton City to Matamata-Piako to Waipa District, or anywhere in between. Where you'd land on the first page within the dashboard as you look at, this is Taupo District, and it shows a Taupo District summary here if you see my cursor on the left. And then by clicking into communities, you can dive down to any community within the Taupo District. You'll see here on the left-hand side, while this is a Power BI dashboard, so informed by millions of rows of code that sit behind the dashboard, we table this up so it looks like a website, so it's really easy to use, and that's important because most communities, when they're deciding locally, they don't have access to PhD level researchers or data scientists. For many people, while they may have experience in the health sector, many of the decision makers will be locals who could be policy analysts, or they could just be regular people who've come to work in a job in the sector. So they need it to be accessible, easy to use, and quite intuitive. You'll see here there's data relating to access to services such as travel times to public health services, medical centres and the like, or access to things like electricity for warm heating their home. Good quality and safe drinking water. As you'll know, this is really important in order to ensure that people aren't made sick just simply by drinking water. We'll look at crime as well. We'll look at local population demographics and how that's split out ethnically by women and men, and the age-sex structure, i.e., for example, is it a young community, is it a more elderly community, or is it a community that's largely focused on families? We look at deprivation, and this is really important because deprivation levels within a community have a high correlation and a very high determinant for health, education, and life outcomes. Likewise, we look at some economic factors, i.e. the number of businesses and what sectors they operate in, and also the local level of consumption, so consumer spend on a daily basis, whether it's taking place locally, does it come from out of town, and they're really important factors to help inform our deprivation analysis as well. If there are good local level jobs and they pay well, people are less likely to be unemployed, they're more likely to have life choices, they may be able to heat their home, they might have internet access, which helps with education and children's education. There's a whole range of factors that will contribute towards, which give them ultimately better health outcomes. So you might ask questions like, well, why is internet access important later in life for health? Well, internet access is currently the single strongest correlating factor or indicator for deprivation outcomes later in life. And that's families that can afford to have access to the internet, afford to have a tablet. Indications show or are that those children later on in life will score better in NCEA, more likely to lead to tertiary education, more likely to tertiary or vocational education, more likely to earn better, and therefore likely to have better health outcomes. And likewise, education is a factor here, employment, environment, such as safe swimming sites, and air pollutants, so air quality, and then gambling, health and housing. For health, we're progressively entering in data going back to 2002, so for the last 20 years across a range of health metrics. At the moment, I think we've got about 5 in there because it's a hugely extensive database. So things such as oncology rates, teen birth rates, mortality, and the like. But here's an example of Taupo district. You see here median household income for Taupo district as a whole, 76,000. Rental affordability is based on the median rent price here and the median household income. So 29% of income is spent on rent, which is okay. Anything less than 30% is okay. Home ownership levels are 43%. That's determined by the number of individuals who own their own home. And then things like crime rate, deprivation rate, and job seeker support rate. If we flip into a neighbouring district, so Hauraki district, we'll see there that median household income is lower at 60,000. Rent price is not much lower, and as a result of that lower income and the median rent price being vaguely similar to Taupo, 34% of all income is being spent on rent. Home ownership levels are higher, with property prices being slightly lower, and deprivation index level there is an 8 though. Comparatively, we go to somewhere like Tokoroa Central. You'll see here the crime rate compared to Hauraki, where it's a 33, static crime rate's 33. So that's the number of crimes or victimisations per 10,000 people per month. So it's normalised for population. Hauraki Central is 340. There's one factor that will contribute to that, and that's it being a retail precinct, so it'll have higher levels of shoplifting. There are bars in close proximity to Tokoroa Central, and tavern proximity is a high indicator for a number of offences committed, particularly in relation to assaults and sexual assaults. But you'll see there the median rent price, while lower than Hauraki and Taupo, is still relatively high in comparison to the median household income, which is very low at $49,000, and therefore 35% of all income is being spent on housing. Home ownership level itself, though, is okay. It's fairly reasonable. Again, that's because purchasing a home in Tokoroa is more affordable at a median property value of $292,000. If we want to jump into any community and see access to services, so I've gone into Matamata Piako. I can select any individual community within Matamata Piako. So Hineamaru, Mangaiti, Matamata, Morrinsville, for example, and we can see things like access to water. This is defined as access to safe drinking water. Walking time to primary schools, travel time to public hospitals is 5 minutes. And you'll see there that for Morrinsville, that's not a problem. 5 minutes to public hospital isn't an issue. But if you're in Rangatike, in Mokai Pātea, or if you're in Ngāmatea, that's more likely to be 100 minutes, so 1 hour 40, and which creates some significant barriers for things like vaccinations, be it COVID, flu vaccinations, or anything else. And so therefore, that could help explain why those areas might have low levels of vaccinations. So it's something we can measure. We can measure travel times for communities for any community service or facility. So whether that be access to playgrounds, access to parks, access to beach or recreation areas, we can insert those and put those in whatever's needed. Crime rates, we're having a look at crime in the Waipa district, which is pretty good because it's quite low. I'm not sure what that bell means. It means wrap it up quickly, I think.
Oh yeah, so that's your 5-minute warning, Justin.
Oh, great, thank you. Well, I'll wrap this up, and then if there's a chance for any questions. We'll see there Waipa crime is low. One, having a national ranking of 1 would be the highest levels of crime in the country, and 68 being the lowest. So Waipa is sort of in that bottom third. Hamilton, on the other hand, ranks as one of the highest, or first equal in the country. So we've just jumped into Hamilton there. And you can see that Hamilton is first, followed by Rotorua, Napier, Palmerston North, Christchurch. And that's because Hamilton has very high rates of theft from motor vehicles, theft of motor vehicles, assaults, and also some high levels of unlawful entry, breaking and entering. We could go into a place like Paeroa just to see what are the population demographics of the place in Paeroa. So 4,579 is your local population. As you can see there in yellow, this is how it breaks down by the age distribution. So a much older community than for the rest of the average of New Zealand. Also quite the large proportion of people that live in Paeroa are European, but Māori population is higher than for other parts of the country as well. And again, you can break that down into very small communities. Deprivation I'm showing here, we've gone to Waitomo district. It's one of the more deprived parts of New Zealand. You'll see here all the areas in dark blue are the more deprived locations. So that's largely through the central North Island and also the far north. An emerging area of high deprivation is the west coast of the South Island, as they've continued to lose jobs over the last 7 to 9 years, particularly in the energy sector. So that's an emerging threat or issue for west coast of the South Island, but also South Taranaki, New Plymouth, Stratford and Waitomo as well. You can see similar sort of story for South Waikato, high levels of deprivation and increasing over time, certainly over the last 7 years. And Tokoroa Central is very consistent, but consistently, unfortunately, poor in terms of deprivation outcomes. So very high levels of deprivation in Tokoroa, and that's matched in surrounding districts like Kawaroa, Portiki, even getting into areas of Whakatane district as well. Just a quick snapshot of their businesses opening and closings. That's been interesting over the last sort of while. We've seen spikes here as COVID wage subsidies have come off. But generally, it's a pretty good story for most of New Zealand, with more businesses opening than closing. And that's really down to the optimism of human endeavour. I think people are always optimistic that things will go okay until they don't. Likewise, we can have a look at domestic tourism and local consumer spending. You see those peaks and troughs here in Taupo district, big peaks up here in around the January Christmas period over summer, and then decent troughs down here, and that's actually the Auckland lockdown that occurred in August 2021. You'll see there a decent chunk of Taupo spend comes from Auckland. So again, important for local businesses to understand. Similar story for Waipa, much more locally focused on their spend, although Hamilton City is a big contributor there. And then we can have a look at things like education as well. We look at secondary school retention, we look at those leaving with NSA level 3, and we take that down to a school level, and we can break it down at the school level by Pakeha, by Māori, Asian, Pacifica, Mila, which is Middle Eastern, Latin American and African, just to understand how people are performing at school and what level of educational attainment they'll attain. And then obviously very important for deprivation analysis is the level of employment or those active in the workforce. And the final one I'd talk to you through is just around air quality and safe swimming sites. So just making sure that air quality is good, which it largely is for most parts of New Zealand, and safe swimming spots, which aren't as good. But the good news story is that they are slowly improving. As you can see here, in and around water quality, so total nitrogen levels that have been measured in around Lake Taupo and surrounding waterways, a whole lot that are degrading over time for a long range average, but what we've seen is more recent 2 to 3 years, for example, things are picking up. Cool. Any questions on those? That final page is showing you some of the health statistics we can analyse as well. And again, as I mentioned, we've got about 5 measures here, but we're looking to incorporate about 15 to 20 and dating back for the last 20 years. Any questions?
Thank you very much, Justin. We have got a question. Someone has put it in the anonymous, put it in anonymously into the question and answer, so I'll read it out. But so is there any kind of data dictionary explaining the indicators shown? And is there some kind of compact map for navigation through the multi-layers of the dashboard?
Yeah, there is. So everything's filterable from the highest level. So if you go to that first page, you can choose any one of the districts from around the country, and you can search for one that you want. We haven't got a mapping function that goes across the top of that, but we could quite easily put that in, as it's another way for to act like a contents page rather than clicking on the name. If you don't know the name, you just click on the district. So that would be quite easy for us to put in. And sorry, you mentioned the other component of that question.
Is there a data dictionary? Is there somewhere that someone can look through all of the available indicators and how they're defined and where the data comes from?
Yeah, so we've gone a step further than that. There's called a dot library, so a data library, and we've got then just definitions of all the metrics. So we measure about 71 different points, and they all have subsets with definitions. So we can just send that to anybody, and it's also displayed in the methodology page. But then we also, as you hover on the dashboard itself, any one of the charts or the data points that you're looking at, we have that, it's called a tooltip. And when you hover over it, it shows the data source, it shows the definition, it shows when it was last measured, and it shows the frequency of the update, i.e. it was last measured in July 2022, and the previous time before that might have been June 2022. And so therefore it measures a change over time as well.
Great, thank you, Justin. And is it publicly available? Can we all just go and have a look, or?
No, it's not. It's a tool that's been developed by us, but it is that's a decision for the councils that are clients of ours, or for example the localities. So Health NZ has a license, and we'd love for them to make it publicly available to the public health professionals. The PHOs have licenses, and likewise they share that with GPs and medical centres. But if we made it public ourselves, and obviously we have a whole lot of people who aren't being paid to do their work, it's up to our clients what they do.
Yeah. All right. Thank you very much, Justin. Unfortunately, we've run out of time, but thank you very much for sharing this with us. And I'm sure people can get in touch with Justin to ask more questions.
No problem. Thanks. Have a great day.
Thank you. And so we're up to our final speaker for the day today, which is Joanna Swanson from the Health Quality and Safety Commission. Is Joanna online?
Kia ora, Ruth.
Joanna
unfortunately can't make it today, and so I'm afraid you've got the B team, which is Alexis and I.
That's quite all right. All right, well, I will hand over to you again, Catherine, to talk to us about the patient experience of care survey. Thank you.
Thank you. So this is a shared presentation. Obviously, Joanna Swanson can't make it today. Alex has COVID, so you've got Alexis and myself. So kia ora koutou. Really delighted to be sharing the results of the patient experience Explorer tool with you today, and give you a quick overview of the patient experience program. If you haven't heard of it, I think it's a really excellent piece of work and can really contribute to what we know about how people are finding their care. And, you know, it's been really exciting to see the PIORA legislation come in. We've seen a lot of consumer engagement explicitly put in legislation, so the Consumer Code of Expectations, as well as the requirement to be including consumer and whānau voice and communities into healthcare planning, which is, you know, it's huge, actually. It's quite a substantial shift from where we've come from. And it'll be interesting, and we're hoping to see localities and the iwi Māori partnership boards really start to engage with this sort of survey data, because it can really tell us a lot about what's happening for people out who are receiving care. So we can just go to the next slide. I think it's really important to make the distinction between patient experience and patient satisfaction, because they can be used a bit interchangeably, and they actually mean quite different things. So patient experience asks people what did or didn't happen during the consult or during the visit. So were your medicines explained in a way that you could understand? This is quite distinct from satisfaction, which is how did you feel about it? Or, you know, how did you feel about the quality of your care? So while we do have some measures on satisfaction around, you know, were you happy? In fact, you can be very happy with particularly poor quality care. And the analogy I often use is that with me getting my car serviced, where I know very little about cars, And if they vacuum it out, I assume that means they've done a good thing under the hood. You know, I think we've got quite a power and information differential with our health visits as well. So it's really important that when we're surveying patients about their experience, that we are checking whether or not the right thing did happen. If you were referred for a lab test, did you know how you were going to get the result? Did you, in fact, get the result? And was it given in a way that you could understand? In terms of the benefits of measuring patient experience, there's been quite a lot of work done. And look, it's not, I think it's really intuitive, and we can all just kind of grasp quite easily that if patients are communicated with clearly, are partners in their decisions, their physical and emotional needs are met, and their care is coordinated, that funnily enough, things like adherence to the treatment and use of preventive services will improve. I think it's sometimes we don't need studies to show us things that I think we know are true, but nonetheless we do have, this one's actually a systematic review, and there really is good evidence backing it up. So if we go to the next slide, this is just a quick kind of gallop through our survey program. So the history of the patient experience surveys really was that back in the day, quality and risk managers in each DHB were meant to be running regular surveys. This wasn't happening. And in 2014, the Commission implemented the National Adult Hospital Inpatient Survey. And that survey's been running in every DHB since 2014. And then in 2016, we began phased implementation of the primary care survey. Obviously, it's a really big survey to implement, and it took quite a while. So we started off with 5 pilot PHOs in 2016, and we're now up to somewhere around 940 facilities participating each quarter. So it's huge, and it's actually probably the biggest health survey that we have in New Zealand. We sample around 180,000 patients each quarter and get around 30,000 responses. Which means that in a year we have about 120,000 completed responses from the primary care survey and just under 12,000 for the adult hospital survey. So it's a really big data set and tells us a lot about what's going on. It's all done online, so there are some holes, you know, we're not hearing from everybody. And the invitations are sent via email or email and SMS if you're Māori or Pacific. What we can say is that in the primary care survey, invitation method is meaning that we're actually getting a slightly higher response rate for Māori than we are for non-Māori, non-Pacific, which is really exciting. But our response rate for Pacific remains to be improved, is probably what I could say. When we design the questions, they're really intended to give you actionable information. So if somebody says, actually, no, I wasn't as involved in decisions about my care and treatment as much as I wanted to be, they're then asked a follow-on question to understand what it was that went wrong. The idea being that we don't just want to get a score out of 10 for were you satisfied, we actually want to know what went wrong and how can it be improved. If we can move to the next slide, I think I hand over to Alexis.
Kia ora koutou. Yeah, it's over to me to show you a little demo of the Experience Explorer that we have, this online tool where you can access some of the data and some of the results for the primary care survey over the last 2 years, I think we've got of data nearly, and also the hospital inpatient survey, but I'll just demo the primary care one for now. So this is the front page that we have on here. There's a little description of the survey and the Explorer itself. We have a couple of buttons in the middle here. Firstly, the topic overview. If you click on that, it gives you an indication of what topics there are within the survey and a little description of each one. The question overview right next door gives you a list of the questions available in the survey within each topic. So you can see questions on the most recent experience, on long-term conditions or medication within the survey. Below, you can click on results by topic or results by question to see the results for an entire topic at once, or the results for one question in a more detailed breakdown. There's also methodology available, and then in the top right here, you've got a couple of little buttons for about the survey and a help navigating around the survey little description. So I take you through the results by topic. And this is what it would look like when you come to the results by topic page. This app is based off the New Zealand Health Survey's Explorers, the regional and annual Explorers, in particular the regional one. So it has a relatively similar structure, and for those of you who are familiar with that, hopefully this is not too far away from that. So here you've got a little description of the topic that you're dealing with. The most recent experience is the default one. In the middle, we've got some charts to show all of the questions within this topic. Firstly, healthcare professional listened to them, kept informed as much as they wanted, and was explained things in a way they could understand. And the results are broken down by the response options. You've also got the results for all ethnic groups and for Māori labeled right against each other. And as you may be able to see as I'm hovering over the bars, you can see a little bit more information about the exact numbers that these bars are referring to. So that's the main front page of this topics page. If we click on, instead of chart, we click on this table tab in the middle. It shows the same results, but just in a table format, so you can see the results a little bit more, the numbers a little bit more cleanly than before. And then thirdly, there's a question list, which gives you an indication of which questions there are in each topic. You can click on one of these to go to the questions page to show the results for that question in particular and a more detailed breakdown. Now on the left, there is a series of filters on this sidebar. So you can select from the topic you want to look at. You can select the time period you want to look at. We default to the most recent time period of data we're publishing, which is February 2022. But the May and August 2022 survey data sets will be available in the next update we do. By default, we also show the data weighted. So this means that we have taken into account the age, gender, ethnicity, and DHB population structures of the data of the respondents we get. And so this gives a much fairer comparison between groups when you're looking at the results. Now, when we've done that, we've only made available one filter at a time. So you can only look at either ethnic group, age group, gender, or district health board. The reason being, once you break down by multiple weighted variables, it can reduce the accuracy and become less meaningful than having it at a high aggregator level. So by default, the data is weighted, but you can select unweighted data as well. Once you've got ethnic group or age group or gender or DHB selected, you can then choose a specific group to look at. So say I wanted to look at Pacific peoples, but click on that and the charts should update with Pacific peoples and Māori sitting alongside. All right, pop onto the results by question page. So this page gives a little breakdown of a single question with a few charts to break it down by different demographics. So the question we've got here is, did the healthcare professional involve you as much as you wanted to be in making decisions about your treatment or care? And what we can see from the chart is that 85.9% of people said, yes, definitely, they were involved as much as they wanted to be. And you can see that information over time by ethnic group as well. There's also some subgroup comparisons down the bottom, and then a breakdown of the data by age group. So as before, the data is by default weighted, so you can click on unweighted, thank you, Patrick, to see a bit more information about it. And you can break down by multiple groups here. There are also more tabs available for different displays. But at this point, I might just hand over back to Catherine to continue the presentation. I'll just make that full screen again. There we go. Go for it, Catherine.
Thanks, Alexis. I actually wonder if we should pause here and just have questions. I think otherwise there'll be no time for questions, and that's probably just a nice place to finish anyway.
Thank you very much, Catherine and Alexis, for stepping in at the last moment to share that with us, and great to see Great to see all that. So we do have a question. Does the anonymous person want to put their hand up and actually ask the question, or shall I read it out? Nope, I'll read it out. This question is, so it's good to know that the surveys delve into detail of what's specifically wrong with one's experience of the health system. Do you have any examples of tangible changes in service as a result of the feedback from the surveys?
Yeah, great question. So one example was, and it did actually come from the qualitative results, was one of the PHO quality leads was looking through data by practice, and they saw one patient saying, I shouldn't have to wait 3 weeks to get an appointment at a particular practice. And when they looked at the quantitative data, that practice did have much longer wait times for appointments than everyone else. This was pre-COVID, I would just like to say. The PHO quality person then went and followed up with that practice, and they worked through what they were doing in terms of the triaging and managing the patient appointments, and they were able to make some changes, and they then did actually see the responses in the survey itself change as well. So that was a really nice example of actually just one qualitative comment being enough to trigger somebody to go, okay, that doesn't sound quite right, let me explore that further. And I think often with the surveys, yes, we get a lot of quantitative data, but one timely comment can actually be enough to tell you what, where there's a problem.
Thank you. Any other questions? No, it is Friday afternoon. I don't understand.
Just the fact that anybody's here at all is outstandingly good. The sun is shining here in Wellington, so, you troopers.
For a change, yes. Yeah. All right, well, thank you very much, both of you, for presenting to us, and for Catherine for presenting to us. And so thank you everyone for sticking with us for our final afternoon of our first PHONZ Hui, and hopefully the first of many, I think, Barry. And it's been a great 3 weeks of all sorts of fascinating talks, and I'm going to hand over to Barry for some final thoughts.
Thank you, Ruth, and thank you, everyone. I think that I echo what Ruth just said, is it's been far exceeded the expectations that we had when we came up with the idea. I think that one of the things that's come out of it is the huge, vast array of excellent work that's going on, and unfortunately totally unconnected in many instances. And I think that's one of the roles that we envisage PHONZ having, is that we are going to connect people up so that all the excellent work that's going on various agencies can actually be shared, so we can progress more. So it really comes back to something that we have noted before, that it's the workforce is limited, despite the fact that we're all here, but it's also very fragmented. And as I said, that's one of the goals of PHONZ, is to address those kinds of things. As Ruth said, this is just the first of an ongoing series. We'll be having these, based on the success of this, an annual thing. The other aspect I should say is that we're going to be setting up monthly webinars, lunchtime webinars, and the first one of those will be at the end of August. We've also got one penciled in hopefully for September and one in October. So if anybody of your colleagues wants to have an expanded presentation, let's know. This is a way in which we can keep the momentum going. Again, they'll be recorded as well. And we're also, the steering group is looking at addressing one other issue that's come out strongly, and this is providing some training for people. And I know that one of the colleagues, Chris Kelly, and I have been talking about how we can actually start implementing some training across the sector for that kind of public health intelligence, or whatever it is. So thank you to everybody that stuck with it. We're delighted that even now, usually at this time in most face-to-face conferences, they've all sloped off to catch an aeroplane, or in fact gone to the pub. So we don't know, maybe you've got wine glasses hidden somewhere we can't see them. But thanks to everyone. A special mention to the steering group. Great success. Thank you to that. And of course, the hidden maestro that's organised it all is Patrick, and you've done an outstanding job, Patrick. So thank you for that, and thank you, everyone. And I think, Tim, you're going to do the close. You're on mute, Tim.
On mute, classic. Nā mihi Ruth and Barry for chairing some of the sessions today. I'll close with the karakia. Karakia tātou. Nā mea I ngā hua, o te wao, o te ngā kina, o te waitai, o te wai Māori, ngā tāne, ngā ronga, ngā tangaroa, ngā maru, ko ranganui I tu iho nui, ki papa tukunuku, I toko koutou nia, turu whakamoa, kia tina, tina, hui e, tai ki e. Ka pai, everybody.
Thank you. Thank you, everyone. Well done.
Thank you. Kia kite.